Hello,
Check, check,
hello,
check, check, check,
hello,
check. 1 2 1 2 खोल देना जूम का.
hello,
हेलो.
hello, hello.
तो बात कर लो. हेलो.
Hello,
हाँ जी सर.
General Raghunath here.
ओके.
Are you starting now?
कितने ज्यादा है?
2 p.m.
हेलो, नमस्कार। ऑडियो चेक ओके?
Yeah.
Okay. Namaskar, everyone. Welcome all respected dignitaries, eminent scientists, medical experts to this oration session at National Academy of Medical Sciences. May I request the chairpersons, Lieutenant General Velu Nair, to please come on the dais. Dr. M. Kar, I would request you to please come on the dais. Dr. Kar, please come on the dais, sir. And our orator for the day, Dr. S. Bose, may I please request to come on the stage? Our chairpersons for this session, Lieutenant General Velu Nair, President-elect National Academy of Medical Sciences, honored with Param Vishisht Seva Medal, Ati Vishisht Seva Medal, Vishisht Seva Medal, and VSM and Bar. He is recipient of 20 prestigious civil oration awards for various national societies. Please give him a big hand. Dr. M. Kar, he is working as Executive Director and CEO at All India Institute of Medical Sciences, Darbhanga, Bihar. Dr. Kar also bestowed the Fellowship of American College of Surgeons, Fellow of Association of Surgeons of India, and Fellow of International College of Surgeons, along with Fellow of the Indian Association of Gastroendoscopic Surgeons of India. Please give him a big hand. As we all know that National Academy of Medical Sciences is the prestigious organization working for the awareness and betterment support of health. कहा जाता है कि हर परिवार में रीत होती है, कुल रीत। हमारा नेशनल एकेडमी ऑफ मेडिकल साइंसेज भी एक परिवार की तरह है और इसके जितने भी कंट्रीब्यूशन है सभी के लिए उसी पर समर्पित है ये कुल गीत। तो आज के कार्यक्रम की इस ओरेशन सेशन की शुरुआत करेंगे इस कुल गीत से। इस कुल गीत में सभी विशेषताएं जितने प्रयास नेशनल एकेडमी ऑफ मेडिकल साइंसेज द्वारा किए गए हैं उन सभी को दर्शाने की प्रस्तुत करने की कोशिश की गई है। And our first orator for the day is Dr. S.M. Bose. He is a cancer specialist with lifetime devoted to the cause of cancer treatment. He is former senior professor of surgery of two of the most prestigious medical institutes of India, PGI Chandigarh and All India Institute of Medical Sciences, New Delhi. Dr. Bose has keen interest in breast cancer and has also done pioneering work in malignancies of thyroid, hepatobiliary, and GI tract. Ministry of Science and Technology honored him with National Award for his outstanding efforts in science and technical communications. As we all know that breast cancer is the most common cancer among women in India, that accounts approximately 1/4 of all female cancers that occur. Factors like increasing age, obesity, harmful products, intake like alcohol, and family history of breast cancer increase the risk of this deadly cancer. And the most challenging part is that this cancer is detected at a very late stage. The orator, Dr. Bose, will be talking about breast cancer scenario in India, its problems, and what are the solutions. Dr. Bose, please come on the dais and deliver your lecture, please.
Good afternoon, chairpersons, Professor Ganguly, esteemed guests, ladies and gentlemen. I am grateful to the President Behra and the NAMS Council for giving me this honor of interacting with you all on a chosen subject of breast cancer in which I am very much interested. I bring to you greetings. I'm going to talk to you on breast cancer. What is the current Indian scenario? What are the challenges it presents before us, and what it should be our role in this disease control? Earlier, breast cancer not commonly seen in India. Globally, every fourth minute a woman is diagnosed with breast cancer. So you can very well imagine how common and prevalent is this disease all over the world. In India, it was not so common, but now it has become the cancer number one for the woman. And Globocan 2020 analyzed that the incidence is 13.5%, much above the cancer cervix, and 10% of all deaths or cancer in females is because of breast cancer. You must be very careful when I say that 1 in 20 females in India is likely to develop breast cancer during her lifetime. Indian population is high, very huge. Some say it is 135 crores, some say even up to 160 crores. And to have such a massive population and with such a prevalent and common disease, it is impossible for the government to manage. Even to provide basic treatment is not possible. COVID-19 has worsened the scenario. There was delay of treatment of these patients by many months, many years. Influencing etiological factor, although the exact etiology of breast cancer is not known, millions of dollars are being utilized all over the world to find out the answer why breast cancer occurs. And the day is not far, I am sure, when it will be possible to find out why breast cancer occurs. And only when we know the reason why breast cancer occurs, we will be able to control. But in India, the average age is 50 as compared to Western, where it is 60 or 70. And we all know the cancer breast, if it happens at younger age, the prognosis is worse. The risk factors are reproductive, lifestyle, environmental. Incidence is increasing in India because of rapid modernization, westernization, unhealthy food, fast food, consumption of alcohol and tobacco by the ladies. This has increased very much in our country, and this is probably one of the factors for increasing this. It is the mainly hormonal, early menarche, late menopause, nulliparity means a woman does not produce any children or does not have a child, late stage of first childbirth. It is said that if the lady has a first child after the age of 30 or 35 years, the chances of breast cancer is much more. Absence of breastfeeding. Yeah, because of the work culture and other culture, the ladies don't have time to feed the babies, and this has got a detrimental effect. Use of contraceptive pills. The genetic aspect, BRCA1 and 2 are not readily available in our country. Some labs are there which is doing it, but it is a very, very costly and I think not very dependable, not in all the labs. Genetic screening is therefore infrequent, although it has been said that all the patients above the age of 60 years and for all which have got maternal history of breast cancer should undergo this genetic screening. hormonal receptors. In India, the hormonal receptor ER/PR is less. It is only 20 to 40%. And whenever the hormonal receptors are positive, the prognosis is better because you can give these patient anti-hormone treatment also. Similarly, triple negative cases are higher, which has got a bad prognosis. Both these are associated with 5-year overall survival is directly linked to the stage at which the patient comes to the doctor and start treatment. In stage 1, which we hardly see in our country, the survival is 95%. In stage 2, it is 92%. But in stage 3, it is 70%, and in stage 4, it is 21%. And most of our patients come in stage 3 and 4. As a matter of fact, more than 60% of our patients come in stage 3 and 4. And this decreases the survival and also increases the cost of treatment. Investigations are done all over the country, but they are also not readily available everywhere. They are very costly, and in government hospitals, there is a huge queue. The waiting period is 3 to 4 or 5 months for PET scan and other. And at other places, these imaging facilities are so costly that a common or even a middleman cannot undertake this. PET scan, MRI of breast, digital mammography, bone scan, ER/PR, HAR2 new receptors either not available in majority of our centers or are not affordable. Sentinel node biopsy is available only in a very few centers. The role of mammography, the basic thing which can be done by either ultrasonography or by digital mammography is the first imaging investigation that is done. Sensitivity is 64 to 90%. Screening is not an option because in other countries, screening is a must. But in India, it is not possible to screen such a huge number. But it is done usually to see whether the disease is only in one breast, whether it is a multicentric, or for what is the exact size of tumor, so that it can guide us for the treatment otherwise. The preoperative diagnosis, one must have it. Without a histopathological diagnosis, one should not go in for treatment. Because in majority of the cases, a good competent doctor, surgeon, or an oncologist, only by physical examination can diagnose the disease in more than 90% of patients. But if you make mistake even in 1%, it is not excused. So you must have a histopathological. And for that, for palpable lesion, it is the fine needle aspiration cytology, core needle biopsy, which is supposed to be better, excision biopsy, where the FNAC or core needle biopsy are not possible. FNAC, the diagnostic accuracy, the sensitivity reported is ranging from 80 to 98%. But sensitivity and positive predictive value approaches 100%, as false positive results are very rare. But here, even in FNAC, it can be wrong. It is better to do it under ultrasound guided. For example, if you see the tumor here, and if the needle goes not in the tumor, but at other places, then it can be negative. Whereas if the needle hits the tumor and you aspirate, then you are sure about what you have done. And so it is always better to do a FNAC under radio imaging, either ultrasound or mammography. Possibilities of false and false negative results under imaging is recommended. Not applicable or clinical practice converted large number of early disease into advanced stages. True cut biopsy has come recently. It has all the advantages because here you take out the tissue and there are more competent pathologists than cytologists in our country. A pathologist can analyze the true cut biopsy specimen very better. It has all the advantages of FNAC, but is painful. It provides the histopathological details of the disease. It can also give you the hormone receptors like ER, PR, and HER2. You can find out from the true cut biopsy specimen, which is helpful in planning your treatment properly. But in cases where the FNAC or true cut needle biopsy is not comfort available, or the results are not conclusive, does not match the physical examination, then excision biopsy is also done in few centers. But do it as for you are giving incision for lumpectomy, segmental mastectomy, or MRM. Here, what I used to do is, if you are seeing the specimen in the depth, you are seeing here, but you must do it under ultrasound guided, remove this. And after removing it, I used to get a X-ray, soft tissue X-ray. So you are sure what you are seeing in mammography, you are excised it for biopsy. Otherwise, you may take out from here and then you are not sure what you have removed is really the disease portion. Non-palpable tumor, where you cannot palpate the tumor from the surface, it can be done either by non-invasive means, invasive method, or stereotactic biopsy. This is the mammatome by which you can remove the biopsy pieces and send it for histopathological conversion. The other investigations, dependency upon investigator. We have learned the bad habit of not undertaking clinical examination, thus making many important aspects, missing many important aspects of the patient. Like, for example, this patient. The surgeon was thought this is a only stage 1 disease and was going to operate. But when we examined him completely, we found there were supraclavicular nodes also. And this revealed that there were pulmonary metastases. And so this was a patient of stage 4, not of stage 1. But if the surgeon has not examined the patient thoroughly, then it was wrong. So you must examine a patient completely. Similarly, this patient, you can see this patient came in, what he thought this is all right outright. But if you see, there are subcutaneous nodules all over the abdomen. Now, coming to the treatment, the goals of treatment. Goals of treatment should have long-term survival, good quality of life, and good cost basis. The most important is the long-term survival. We must be able to give the longest survival time to the patient, so the effort should be of this. Then comes the good quality of the life, that the patient should be able to do everything he wants to do it. The last comes the good cost basis, but this is also important for a lady. This era, it is the multimodality treatment. Earlier, it was either the surgeon or the physician who is to treat. But now, the important is of chemotherapy, surgery, radiotherapy, hormone therapy, target therapy, and immunotherapy. A patient may require either 1, 2, or 4, or may require all the 4, 6. So depending upon the stage, depending upon the histopathological examination reports, depending upon the markers, etc., one has to combine. And so it is now said it is a group therapy right from the first day. When the patient comes to a doctor, the patient is seen by a group of doctors, which includes surgeon, chemotherapists, radiotherapists, medical oncologists, and all. And from they discussed every aspect of the patient, her progress, and then the treat patient till the last. There is no uniform standard of treatment. I'm sorry to say this. In India, there is no uniform treatment. There is no protocol which is followed in all the hospitals or in the same hospital. Different surgeons will follow the different protocols. Less than 50% of patients are given current rational treatment, and this we have to work on. The commonest operation done for breast cancer in India is the MRM, that is modified radical mastectomy, in which the entire breast is removed along with the axillary contents. Sorry. Along with the axillary content, and then the patient is given this. This is good, gives very good result, and is available in most. But because it gives a very bad scar or figure to the patient, so they add now the cosmetic enhancements, either by putting in the implant or by putting in a LD flap, or some patients are given even a TRAM flap. These are the accessory operations done to give a better look to the patient. Now, this is also very important for us to remember that the breasts are the assets of a woman. It is symbolic of grace, beauty, and elegance. We used to think that Indian women are not conscious about their figure. But we conducted a study way back in 1980. One of our MD students in psychiatry, he did a thesis under us, and our results were that irrespective of the age, education, financial and social stage, they are very much concerned with their figure. Loss of a breast gives her psychological trauma akin to loss of femininity. Even we had few patients who thought of committing suicide because she had lost breast, her family's social life had gone. And this gave us the impression that our female patient also is important for us, and breast conservation is very much needed in our society. And from then onward, from 1980, we thought of starting breast conservation surgery. But breast conservation surgery is only possible if the patient comes at an early stage, small tumor. If the tumor is large enough, like if it is a large, then you cannot preserve the breast because you have to remove so much of the breast. What will be left? So it is very important that if the patient wants breast conservation, then the patient should come to us. In breast conservation, we again, small incision, remove the breast. Sometimes we may use 2 incisions, one for removal of the breast cancer, another is to clearance of axilla. If this is the tumor, all around, we must have a free margin of 1 to 2 centimeters. And irrespective of the age, if we are able to give a good figure to the patient. This is another showing the same thing. See, there is a clear-cut margin or 1 to 2 centimeter around the tumor, and this is the axillary contents. The specimen is removed, and then we mobilize a flap of the breast tissue, put it here to fill in the gap so that we are able to give a good figure to the patient. But breast conservation is not possible if it is a multicentric tumor. The poor cosmetics because of the large central tumor, patient not willing for breast conservation surgery, or she is not willing to come for regular follow-up throughout her life, and radiotherapy is not. Although without radiotherapy also, but if you add radiotherapy to the patient who have got breast conservation surgery, the prognosis becomes much better. This is again a patient, I said is central tumor we usually, but this is a patient who was young and said, no, I want breast conservation. And we were able to remove this. This is the periareolar incision. And through this, we went in, removed the tumor, and have been able to give a good cosmetic result to this patient. Similarly, this patient has a very large size breast, and she said it was central, involving the areola, but she said, no, I don't want to lose my breast. And we did it. We did the excision of the tumor and axillary clearance, give her this, and she survived for 10 years that I used to follow her. After you have done the breast conservation, it is very important to assess the resection margins. Because if you have left behind a tumor, the chances of recurrence is very much. And this we did even with imprint cytology. But later on, we come to know that earlier what we used to do is, if this is a specimen, we will, after removing the specimen, we will take out the biopsy pieces from here, and see if it is positive. But then we thought better will be if this is the cavity left behind, and then from the cavity, not from the specimen, from the cavity at 12, 6, 3, and 9, we took out the tissue, have a frozen section, and if was biopsy, then on the table, we can excise the mold. And this gave us much better results than otherwise. Breast conservation surgery, as I said, is best for early breast cancer, possibly stage 1 and 2. But then we thought, why not try it for patients who come in late stages, that is late stage 3. Breast conservation surgery is not a common modality of treatment in our country, and it is much less in cases of locally advanced breast cancer. But we thought, let us try. And this is a newer concept, attempt to provide breast conservation surgery for stage 3. The patient must be willing, understand the risk of recurrence, and good counseling mandatory. This we thought, because even if the local advanced breast cancer patient, we have given the breast conservation surgery, if she comes back, we can still go in and do a modified radical mastectomy. So at least for 5 years or 10 years, she may not have that bad figure as she had. For locally advanced breast, first we give pre-op chemotherapy, followed by treatment. All patients do not respond to chemotherapy. So non-responders and progressive patients, we take them for total mastectomy and axillary clearance, follow it with radiotherapy and hormone therapy if possible. Complete and partial responders, we do MRM or breast conservation surgery, followed by chemotherapy, radiotherapy, and hormone therapy. This is one of the young lady doctor, unmarried, came to me in stage 3. Unmarried, she did not want to her lose breast. We gave her chemotherapy. She responded very nicely, and we did this breast conservation surgery. So happy she was. She got married, although I told her not to get married for 5 years, but she got married after 2 years, and even her husband could not detect it for long time that she had a breast cancer surgery. So at times we can be quite happy to take the risk of providing breast conservation surgery, even these stage 3 patients, but that is not there. This is again a professor in the university. She had bilateral breast conservation surgery. At the same time, this was a lady who did not want breast conservation surgery, and we had to do modified radical mastectomy on both the time. Both of them are now about 82 years, operated for breast cancer, segmental mastectomy, this patient, and modified radical mastectomy, 30-year follow-up. They are still disease-free. And this is a, I think, pat on me that I took the courage, and pat on the female also lady patient that she took the courage to follow it up. The good cosmetic effect after segmental. There are people who say that the breast conservation should be done only for young. I don't think so. Any patient who is willing, irrespective of her age, education, whether she is rural or urban, she is educated or not educated, we should try to give her good. And this was one patient also who also did very well. Biggest problem in India is late presentation. Mean total delay. A patient comes to a doctor or start treatment after almost 30 weeks, which is late. This we have to decrease. Coming to the metastatic breast cancer, stage 4, the incidence is 15 to 25%, and the reasons are illiteracy, lack of awareness, financial constraint, lack of medical facility, alternative systems, or they waste their time, money, and energy on the quacks. Outcome is very poor. But still, we should be able to do something. Like this patient, horrible patient. She is an educated patient, working in the university, but kept on like this. We somehow do external radical mastectomy with skin grafting. This is another patient. She was having so much of pain that we thought we did. And we did operate upon her, and she was able to live with a lot of comfort later on. This is another 92-year female having multiple problems. Again, this patient also we treated. MRM, this is a new thing I have started, modified radical mastectomy under local anesthesia. I got some patients from far east of our country where they had cardiac problem, valvular or anything. And even when they came to me for operation, our anesthesia team were not willing to give any general anesthesia. So I took the courage of doing this patient under local anesthesia. And we have done about 6-7 patients. They did quite well. 1 or 2 patients came who were told by the anesthetist that you go and get your mitral valve or aortic valve replaced. And when she came to that hospital, she found that the charges were about 6 or 7 lakhs, which she could not afford. She was willing to take risk, and we took the risk, and the patient did. As a matter of fact, all these patients have done quite well after local. This is later on I came to know that Higgins et al. they have shown that the peritumoral injection of lignocaine, it blocks the voltage gray channel and their prognosis is better. This has been also tested by Tata Memorial Hospital, where they inject lignocaine all around the tumor and then do the modified radical mastectomy of breast cancer. As a matter of fact, when I am doing under local anesthesia, I am achieving the same thing. The other is the chemotherapy. I will not go into the details, but the patient require adjuvant therapy, chemotherapy, radiotherapy. Radiotherapy has made tremendous progress. It has gone from 2D to 3D. Techniques have been modified. It has become safer, shorter, and segmental. India requires many more radiotherapy centers with specialists. Hormone therapy, again, hormone positive cases are less in India, but they should all be given. Triple negative cases are more. Negative cases require intense chemotherapy. Target therapy, the incidence is also more, and you have to give chance to be, but this should be. Previously, we used to give it for 1 year. The cost is quite a lot. But people have worked, particularly at Tata Memorial Hospital, and they have found a course for 6 months to 9 months gives the same good results as for 1 year, and that it becomes more affordable and patient friendly. The follow-up care, it is well known that a good percentage come back with recurrence, particularly of late stages. If recurrence are treated early and properly, then outcome is very satisfactory. Unfortunately, follow-up is very poor in. There is no protocol, no record. Then another important point that I would like to share with you is the health education and awareness of this 2 minutes I will take. The conclusion, I will say, present day scenario in India is disappointing. For satisfactory management, India requires augmentation of infrastructure, more dedicated center, more competent specialists, procurement of equipment, and implementation of latest technique. Health education and awareness are very much needed urgently and on massive. Cancer, don't get scared, fight it and conquer it. These are some of the books that I have written on the subject. This is the health education books available in 7 languages, published by Government of India. And these are available, they are quite cheap, but people read more of Hollywood and Tollywood material than these books, although these are very important for them. This covers the stories of 16 long-term survivors, means those who have survived for more than 25 to 30 years after the treatment of breast cancer. They are very happy about this. This is my autobiographic book. My regards and tribute to all my mentors and gurus, colleagues, students, and my patients for making me what I am today. To my family for walking with me. Thank you very much for your patience here.
Thank you, sir. This is a very looks small but very vast topic, and you very lucidly point out and summarize the treatment standards from localized disease to systemic disease, then spectrum disease theory. Then we are moving towards vaccination also coming. So many things. This cancer treatment. This best. Thank you so much, lucidly. I think everyone must be understanding that how sir is giving the each and everything of the treatment standards. Now we can move to the next oration. Because of the timing, we will discuss the interactive action after the completion of the orations.
We can take the
Yeah.
questions
Questions
together,
and
sir,
later.
in the interest of time, if you don't mind.
Uh,
Yes, yes.
Thank you.
A wonderful talk. And we move to the next talk on CA cervix. And as a matter of fact, we have Professor Neerja Batla to deliver this oration, a very, very important topic. And I think there's no better person than her to actually deliver this talk. And though she doesn't need a formal introduction, because I think she's well known in these parts. She's was the former head of the Department of Obstetrics and Gynecology, NAMS, New Delhi, and now she actually heads the WHO Collaborating Center for Cervical Cancer Prevention and Research at the same institute. She's extremely well published, and she also spearheads the awareness program, the vaccination program, the screening program, and she's a council member of many societies who contribute to this. And she's extremely well published with monstrous citation index, H index and I index. And with those words, I will invite Dr. Neerja to talk to us for the next 30 minutes or so, and then we'll take some questions from the audience. Professor Neerja.
Thank you very much. Thank you very much, Chairpersons, Dr. Nair, that generous introduction. And it's quite a challenge to follow Dr. Bose, who had wonderful, very simplified messages with very beautiful clinical pictures. So today I'm going to talk about cervical cancer elimination, a feasible goal. Looking at the magnitude of the problem of cervical cancer, the role of the vaccines, screening and treatment of precancerous conditions, and the prospect of cervical cancer elimination within this century. And here I will just take a moment to say that when we talk about elimination, some people think we're talking about eradication, but it's not eradication. Eradication is what we had with smallpox, which probably sits in a small vial only somewhere now. But we are talking about elimination, which means making it a reasonable problem, not the massive public health problem that it is today, something like what we have with polio. And if we look at the site-wise rankings, you know, these numbers come from Globocan, from the International Agency for Research on Cancer, which is the WHO body. They come regularly every 2 or 3 years. And they are about, they're based on the data that come from our registries, and they have some formulas to adjust for demographics, etc. Because cancer is not a notifiable disease, we're not quite sure exactly where our numbers lie, but these are the estimated numbers. And I always feel that more than the numbers, the trends are very important when we look at them. And what we do see is that while breast cancer, and this is global data, is the number 1, cervical cancer is a number 4. And a lot of this is actually being contributed from the parts of the world that are underserved. You see the darkest colors signify the highest incidence, and on the right side, the mortality. And India has consistently been sitting in that number 2 bracket, and neither more nor less, but that's where we want to go, is less and less. And you can see the lighter colors in the developed parts of the world and what they could achieve already by screening programs, and now further heightened by their vaccination programs. What is also a little disturbing is that the mortality should be so high for a cancer that is preventable and amenable to early detection. Even if you do have incidence, you should not have mortality, but again indicates failure of our systems and of us as health professionals. So it was indeed very exciting when Dr. Tedros in 2018 first brought out this call and said we can eliminate cervical cancer as a public health problem through intensified vaccination against HPV screening and treatment. This was all following on the results of Dr. Harold Zurhausen's work. Dr. Harold Zurhausen got a Nobel Prize for his discovery that human papilloma virus is the essential cause of cervical cancer. Necessary but not sufficient. All women who have HPV infection are not going to get cancer. There are cofactors like early sexual activity, multiple partners of your partner, infections, multiple pregnancies, and so on, that we know some help to some extent. Smoking, we knew all this, But the most important thing is HPV. So the vision that Dr. Tedros brought forward, I'm so glad he did this before the pandemic. I think if the pandemic had already come, this cervical cancer would not have reached this, what was going to be the star program of his career. So anyway, the good thing was he had announced it and it went on ahead. The goal was to reach less than 4 cases per 100,000 woman years, which qualifies it as a rare cancer. And the modeling suggested that if by 2030 we can put these targets in place, 90% of girls to get the vaccine by 15 years, 70% of women to be screened with an effective test at 35 and 45 years of age, and 90% of women who are identified with cervical disease to receive treatment and care. Because screening is not going to save lives. You have to treat those screen-detected lesions. So if we could do this, we would be on our road to elimination, and we would also be fulfilling the SDG criteria of 30% reduction in mortality from cervical cancer. So this is how the 2022 figure looks for India, really, which shows that the breast is at number 1 and cervix is at number 2. And the third most important is ovary, actually. But if you look at these 3, which are almost half the pie, this is all which is covered by our National Cancer Program, screening program. And if you see the distribution from the various registries, it is quite variable. It varies from only 4.8 in Dibrugarh to 27.7 Papumpure. Is this real? The 4.8 is the question. Are they really near elimination? It's not a fact because of our registry program having its own lacunae and how well it is being covered. But this is the data that we have, so we go with it. So cancer cervix highest in registries in rural areas like Barshi, Osmanabad and Bid, Mizoram, Tripura, Pasighat, Kachar and Nagaland. The rates are definitely higher in the northeast and in some rural registries like Barshi in Western India. And the highest we have is 27.7, which is way off from our 4 goal. Trends have, as analyzed, have shown a significant decline in the age-adjusted rates in most registries. The maximum decline in Chennai, though still well above the elimination target. And this is the important thing to realize. Some people say we don't need any program, even without the program or whatever we have as a program, it's coming down. Yes, it is, but it's kind of plateauing off. And there are countries where it has declined and even gone up again. So there is no guarantee that it's going to stay low, and it's definitely not reaching the elimination target. And 60% are being detected with local regional spread, which definitely needs to be addressed. So we've known for a long time about the natural history of cervical cancer. In fact, Rigoni Stern talked about it in the 1800s when he found that it was seen more among the prostitutes and less among the nuns, or almost none. And it's also because it's so easy to see the cervix, it's so easy to sample it. It's in fact can be burnt, frozen, biopsied without significant pain. The main pain cervix feels is of dilatation. So we've had this thing about normal going to CIN 1, 2, 3, and then cancer. Now, because of knowing about HPV, that got interspersed in it. It's a very common infection, but in 90% of cases, it gets cleared on its own. And the prophylactic vaccination is obviously useful only when it is given, not only, maximally when it is given before contact with the HPV virus. The various methods for screening we have, like Pap smear, can only detect it at least once it reaches that persistent level. But the coilocytes you see on Pap smear are usually significant low-grade infections. And the VIA detection rate again goes all the way, but you can see that the HPV test has a far higher detection rate, which is the reason why if there's a negative test, it has a far higher reassurance than does the high-grade CIN cancer. And of course, treatment can be done at this stage or even later if detected. So WHO had this life course approach to cervical cancer control for a long time. We know that the HPV infection is maximum in the 3rd decade of life, and gradually as it clears out, it comes down. About 10 to 15 years later, it starts the pre-cancer, and then comes the cancer. And some people who say, why are we not screening before 30? This is the reason. Even in India, if you see the curves, there's very few cancers before 30 and not enough to justify screening the universal entire population, which, as you know, we have very large cohorts. So primary prevention by vaccination and primordial information about health. Secondary prevention after 30 years of age. And there's a lot of loss to follow up. It's a very multi-step thing. You take the screening test, it comes positive, you call her back, you say you need a colposcopy, you take a biopsy, you call her back, you see the report, you say now you need a leap. So the aim is to find a point of care test which will be followed by immediate treatment. And having said that, we don't really have a point of care like a urine pregnancy test, but we do have tests which have a 1 hour turnaround time, which can work. And then, of course, if they get cancer, then as the stage indicates, they will go to surgery or radiotherapy with chemotherapy as an option. And now, in fact, it's opening up for targeted treatments as well. So looking at the first aspect of prevention, which is prophylactic vaccines, we have had 4 vaccines in India. The first column shows the year of licensure and the year in which it came to India. We have the quadrivalent Gardasil now. The bivalent HPV is no longer marketed in India. The nonavalent HPV is available, which has 7 high-risk types. And the quadrivalent by Cervical, by the indigenous one, is now our great hope, which has come from 2023 in the market. 6 and 11 are really for the low-risk types, which cause warts. And that's not such an immediate problem in India as it is in many countries. The high-risk types are there. And what is the basis for these? So I don't want you to get puzzled by this. Just look at the first type. It gives you a bunch of types. There are 100 HPV types. About 30 to 40 infect the genital tract. And out of them, there are about 15 that have some degree of oncogenicity. And the main ones are 16, 18. Look at the first column and look at the last column, which tells you the percent attributable fraction. So you can see that HPV 16 has the highest, followed by 18. And these are the 2 which are being targeted in our first generation vaccines. And the second generation have all of these. It doesn't have 35. This is actually a notable omission because in parts of Africa, it's more common. And even in our own meta-analysis from India, we found South India had more HPV 35 than North India. And Serum Institute will probably address this in their next. But these are the types which we now recommending for reduced valency tests, and I'll come to that later. So basically, these are the types. This is the basis. And the encouraging story for us is that in India, as compared to the 70% that was originally reported and 77% now reported for 16-18, we have about 84% of our cancers being caused by 16-18. And with some degree of cross-protection of related types, this really augurs very well for us to just put the simple first generation quadrivalent vaccine into our national program. And there will be some degree of herd immunity, which will be helpful as well. So all the studies have used the endpoint as CIN2+. This is also sometimes a sort of a criticism that they have only been shown to prevent CIN2+, and have not been shown to prevent cancer, which is a little strange to me because when we do screening and treat the CIN2+, we say this is preventing cancer. So if the vaccine is preventing CIN2+, why is that not good enough? The main thing, it is unethical. You can never have cancer as the endpoint because it is known that the CIN2+ has a high risk of progression. You cannot leave them untreated. There was a very unethical natural observation experiment in New Zealand, which is in published literature, but never to be repeated, which has shown that it is not at all right to leave these patients. So this is what all the trials have looked at, and there have been large trials, large numbers, which have universally shown that they are effective and they are safe. And CDC has even said the vaccine is as safe as a tetanus toxoid. Serious adverse events after the vaccines, yes. Related to the vaccine, causality, no, very clearly. And then this was the publication we had from our trial, which was done at multiple sites with the new quadrivalent HPV vaccine, now named Cervical, which was tried in the non-inferiority trial compared to the existing quadrivalent vaccine Gardasil. And with this, we found that it had non-inferiority for all the HPV types. And in fact, John Schiller and Amy Kramer, who are very noted figures in this HPV sort of community, gave a commentary in the same edition saying an HPV vaccine from India broadens possibilities for cervical cancer control, because we know that our Indian vaccines actually are providing more than 2/3 of the world's vaccination. So I just brought this slide about the adverse event profile of Cervarvac versus Gardasil, and it was consistent with the published data. The AEs were mainly mild or moderate. And the interesting thing was, if you see the red is Cervarvac in the boys, the light green is Cervarvac in girls, and the dark green is Gardasil in girls in cohort 1. And in cohort 2, it's the same for older men and women, 15 to 26-year age group. And you can see that consistently, the boys and men had better tolerability. And just to say that when you go out there vaccinating and what you expect, because definitely while it's not coming to the national program soon, but yes, boys and men should be vaccinated too. I also brought this one slide because there's been a lot on WhatsApp about the premature ovarian insufficiency. And this is always a problem when you go with a gender specific vaccine and say only females, and then people start getting worried and say you're targeting fertility, although now demographic change, we're not really targeting fertility in that way at all anymore. So anyway, this has shown that the quadrivalent vaccine does not increase POI relative to unvaccinated or even other childhood vaccines. No difference of the quadrivalent, bivalent, and nonavalent. And it's just relatable to the worldwide incidence, which we know that POI is increasing, sperm counts are falling, and that's another discussion altogether. Now, I want to talk about the doses of the vaccine, and it started as a 3-dose vaccine, started at the princely rate of $120 a dose when it first started in the US. And the question was whether we can give fewer, because there was some evidence from dropouts that it would work. And so it would be logistically and cost-wise very good, and we started this. And this actually, many of you may have heard about this trial over the years, which is going on since 2009. But it's a trial which is an example of serendipity as well as a story of resilience. Serendipity means you just have an unplanned fortunate discovery, which is quite common if you keep your eyes and ears open. What started out as a large trial for comparing 2 doses at 6 months interval with 3 doses at 0, 2, and 6, which was the standard, turned into a situation where it was abruptly stopped because of deaths in another trial, which had occurred up to 6 months later and had no relation to the vaccine. But there was a knee-jerk response. And this is the situation we found ourselves in. And we found a large number of girls left with 1 dose. The trial lost its randomization, but it was still very good observational data. Fortunately, BMGF agreed to continue the follow-up. So if we did not look at which group they originally belonged to, we had 3 doses, we had 2 doses at 0 and 6 months, we had 2 doses at 0 and 2 who never got their third, and we had single dose. We then went on to recruit unvaccinated cohorts post hoc and followed them up as well for infection. And we watched all these girls as they got married. They were 10 to 18 years to start with. As they got married, as they had pregnancy, we collected their cervical specimens, we collected their blood samples, and we did their detailed investigations. And we got very good papers on the immunogenicity and HPV infection and the vaccination efficacy post. And you can see that the curves in blue and pink of the 2 dose and the 3 dose are completely superimposed when 6 months apart, 2 dose. When in the green, you see when they are 2 months apart, this is a log curve, so they're about 1/10 the level. And even the 1 dose does have, for both HPV 16 and 18, some immunogenicity. We've had a lot of very good publications coming out. This most recent one is the one I refer everyone to, a whole issue of JNCI on single dose from all over the world. Ours is the longest study following up a single dose cohort. Totally serendipity, totally because of the resilience, great follow-ups we have. And never we would have got permission to do a single dose trial ethically if we had gone for it up front. So it was just good news for us that it happened when it did, though it didn't seem that at the time. So we can still see that there is high protective efficacy against persistent HPV 16, 18, and associated neoplasia up to 15 years, average follow-up 12 years, and we are continuing to follow these girls. And I tell everyone who has any naysayers in their administration or in their policymaker to have this. In fact, we saw that there was no difference in 2 doses between the people who were under 15 as compared to over 15. And in fact, that was put to rest. And in our study, as well as other similar studies, have informed the WHO recommendation since 2022, an off-label recommendation that you can do 1 or 2 dose schedules for the 9 to 14 primary target, as well as up to 20 years. And beyond that, 2 doses, 3 doses only for immunocompromised group. And this is what NTAGI has also endorsed, that Gardasil and Cervical may be given a single dose, the primary target group 9 to 14. Cervavax should be 2 doses until we have studies showing the single dose. WHO wants 2-year proof, and ICMR has started this study. WHO has an option of extended interval regimen for 3 to 5 year interval. And we are seriously recommending, our publication is in press now, that this should be considered while awaiting the results of the ICMR study. If you have a captive audience school population, give them 1 dose, wait. There were places like Quebec who did this and successfully with the earlier vaccines. I also refer you to the WHO dashboard. If anybody wants, you can get information on the introduction status, introduction year, delivery strategy, targeted sex, first dose coverage, final coverage, and the schedule. And there are about 145 countries now, and see how many countries are on the single dose, all the orange, which includes Canada, UK, Australia, so many countries, Africa, mostly because of Gavi support, many countries are into vaccination. So what's happened in India? After the initial public backlash, we did have some pilot introductions in Delhi, Punjab, and 2 districts, state-wise introductions, Sikkim, and most recently Bihar. The government is committed for inclusion in the NIP as a school-based program. Sikkim, when they first introduced, had some hesitancy. They needed a focused campaign to educate parents and teachers. This is really important for anyone wanting to do it. And later they could go to 95% coverage. Bihar started in October last year. They have started with the Indian vaccine, the first state to start, and they are awaiting their full supplies. There's the doubts about reducing cancer have been put to rest as the real world evidence has come in. In Sweden, they have seen 88% reduction in the cancers when vaccinated before 17 years, and about 53% in the older women. In UK, they looked at their data after the national program was introduced. They also found a very high reduction, 87% in the very young and 97% in the CIN3+ rates. And they concluded that their program has successfully almost eliminated CA cervix in women born after 1995. And then there are other cancers which are being protected on the side. 90% of anal cancers, both sexes, 70% of head and neck cancer, both more in the males, 60% of penile cancer for the males, and the vaginal and the vulvar. And in most of these, the majority is HPV 16. So again, they stand to benefit. Of course, they are smaller, but they are horrible cancers to have. And why would we not want the protection? And coming to the secondary prevention, now this is a very complex story because there are 3 very valid tests. There's data to justify them all: cytology, VI, HPV. You can decide for HPV particularly whether you want a provider or a self-collection. The self-collection, which was initially vaginal, now urine is also being tested. Then there are triage tools. By whichever test you got a positive, you have to see, is she harboring disease already? So colposcopy, HPV genotyping, biomarkers. I already spoke about the problems of the multiple visit, the single visit. Now we have a lot of portable devices to make it simpler. And then there's a choice of treatment methods, what you will do, and all that involves training. So this is the way it works. Now, in the visual methods, there is definitely facilitation because of the coming on of the built-in AI, and HPV DNA is okay for self-sampling. There's not much data on the mRNA. This is all from the WHO living guidelines, which were developed as part of this elimination strategy and continue to be updated continuously. In fact, our national program really got an impetus in 2016. Something was going on already, but it was really got an impetus when the PM said 3 months for the program. And I was wondering how it will happen, but it did. And everything was turned out in 3 months' time. It's supposed to be at the district level by VIA because we can't afford to have PAP or HPV. And there is all the criteria spelled out for which are the lesions which can be treated there. And then at that time, it was cryotherapy. Now thermal ablation is the new workhorse. But there's inadequate coverage, only half the districts. Oral is more than breast, is more than cervix. Linkages for referral are missing for both treatment and follow-up. We need some navigation systems. When they get there, the curative always scores over the preventive. VIA needs constant training, retraining, QA, and the system issues, transfer of trained workers and all that. So we need also the procurement issues. We have colposcopes, ablators, but where is the procurement? And we have a need for screening registries, which can have linkage with cancer registries. So transition to HPV testing as recommended by WHO, the time is now. It's the most accurate, best sensitivity, NPV. 2 tests can be enough. There have studies from India have shown even 1 has some survival benefit. In vaccinated populations, perhaps 1 will be enough. Self-sampling can be done, but the greatest barrier is cost. So the indigenous tests we have evaluated already, and hopefully they can be introduced. This is a wide variety, and validation is very important. Just doing a PCR is not good enough. If your primers are not right, you will have false results. If you're getting the TAC, which is of a poor quality, you will get false results. It might be worse than doing the hybrid capture. And conversely, you might detect a few which are only analytical and not clinical sensitivity. So there's now a bunch of tests available. The hybrid capture we have in many places in India, but now you have these other ones which tell you 16, 18, and that's great because you know these are the ones you need to treat right away, and full typing, of course, is only for research. So these validation criteria have been set by Meyer, which are the international criteria. And again, I will say that we decided to go for what we are calling an LMIC test, which would have only these 8 or maybe the 7 of the nonavalent is where we started types. And IARC actually had an expert meeting to adapt the new criteria and to lay down these new criteria on which basis we can say this is a valid test. And the reproducibility was equally important too. So we started this study last year with 3 laboratories at AIMS, at NICPR and NIRRCH, getting biobank samples to fulfill the criteria, supported by Grand Challenges India. I'm happy to tell you the meeting's day after tomorrow. Anybody who's interested, please do join us at the auditorium at India International Center at 11:30 a.m. So the hypothesis was that if we have just 8 types, we'll definitely compromise sensitivity, but we just lose that little tail. We don't send everyone to triage, and we have an efficient program. So we validated 4 tests and compared them to the COBAS, which had been done initially, and now done a full genotyping with the Allplex, and looked at the type-specific agreement and the concordance. And the other advantage of HPV, the self-sampling, which is part of the self-care recommendations of WHO, we found it to be very, very helpful. 98% of women could do it, 94% concordance, but there are also systematic reviews to prove it. The device is still a challenge. These imported ones, we did it with the hybrid capture brush, but if you want to hand it to women to take home and do, these add their own cost. An Indian one has come now, but they all perform differently, and we need more, and we need validated ones. This is the next challenge. So even for the colposcopy, we have these devices now which can be done, and AI is being built into them. And for the ablation, as I said, thermal ablation is now the new workhorse, and we have, again, these portable ones. One thing we realized soon after the pandemic, we had this workshop in Prague from FIGO, and different agencies in different countries are responsible for HPV vaccination. Somewhere it's reproductive health, others immunization, adolescent health, school health, cancer and NCD, AIDS control. So we need to really work with these. We need to disseminate the awareness. There are still people who say cervical is just so common these days. There are still media people who publish this kind of news and say cervical cancer se bachne ke liye teekakaran zaruri. and put these kind of pictures there. This is not our cervix. This is our cervix, and we need to know it. Cervix means neck, wherever it may be. So we need to remove the stigma associated with HPV infection. We need to realize that vast majority are going to get this infection. And now we find so many women who are coming in to us because of late pregnancies from the ART clinics, etc., the psychosocial, the economic repercussions. So please encourage vaccination. This modeling shows how it can help. And in fact, I will show you from the same group who says that girls only vaccination, 89.4% reduction, and adding on twice lifetime screening, 96.7. So blue is our goal. This is the year. Look at the countries where they are, depending where they are, they go to blue at a different time, and you will see as the years go by, India turns blue at around 2060, 62 is where it is expected that if by 2030 we do this, then we are going to reach the goal by 2062. So together we ensure that every girl gets her vaccine early enough, enforce the message of screening, preferably HPV testing, but do what you can. Bring forth the survivorship stories. Let not people be hesitant to tell you. Mobilize influencers and public-private partnerships. Government never did anything alone. Rotary helped with polio. Everyone's help is needed. So get them together to get this done. And many thanks to all my team members, mentors, supporters, without whom we won't be where we are. Thank you so much.
Thank you for that wonderful talk. Very India-centric and good to see our data. That too, cancer and infection has always been a challenge because it's preventable. And I think you got it by the jugular here. And I think before I open it to the audience, because we have a little bit of time for some Q&As, I saw a few articles, Dr. Nija. One of them said, boys and girls. So a few words on the boys part and the vaccination of boys.
So,
Usko,
So, it's a little paradoxical that while we are saying people aren't getting vaccinated, we also have a shortage of HPV vaccine. So, in fact, WHO, the last time round, had said, please hold on to boys' vaccination till the girls are done. Because at the end of the day, they have more to gain from it, as well as there will be some herd immunity once you cross the 70% coverage. But now there are more players in the market. There are 2 vaccines from China. There's ours. So now they're saying it's okay to go ahead. But we have very large cohorts, and the government has to decide whether to vaccinate twice the number of girls for the same rupee, or whether to vaccinate both the girls and boys. Vaccinating both the girls and boys, as I said, it has merits. I mean, you can imagine school, if the girls only are going for vaccination, boys are not. There are challenges in the communication also. But conversely, you will cover more girls, and that's where the problem as a public health problem. But because there is definitely benefit for boys, I think everybody who can afford it should take it.
So it's not yet in the national immunization program.
Not yet. It's recommended by NTAGI, and it's in some states because the states pay for it presently. Once it's in the national program, they'll get it from national funding.
We'll invite questions from the audience, comments. Can we have a mic for Professor Ganguly sir? एक mic देना please. ये ले लो इधर से.
Congratulations, Dr. Nirja, for being very persistent. I'm seeing you for last 30 years on this subject. So I have a few comments to make. Actually, Dr. Prime Minister made a provision in this budget to introduce papilloma vaccination nationwide to all eligible between 19 to 13-year-old girls. And actually, the money need to come from somewhere, and that particular effort is going on. Probably we will get it.
Yes.
The problem which I want to say that the Barshi has a very sharp drop of cervical cancer, because it was Tata Memorial Center field station, and they have seen that just by public health measures, the peri-urban Maharashtra and urban Maharashtra, there has been a very steep drop in this. Those you had already talked about, those public health measures. One information I want to give you that China has brought out a messenger RNA-based E2, E6, E7, the therapeutic cervical cancer vaccine. So they have completed the phase 3, and it's only need to be, so they have contacted Indian companies that whether they will like to license it in India. So there could be a therapeutic vaccine, and that will be in addition. And I want to say for the audience that Dr. Batla, she showed this small colposcope, which could be introduced by nurses or class 8 to 10 girls. She went to Bangladesh. India was not using it. She went to Bangladesh and trained the girls there to screen for the cervical cancer. Thank you for your.
Yes, thank you, sir. Actually, I didn't, I have a slide for the therapeutic vaccine, but in interest of time, I've removed that because that's a little more futuristic yet. But there's a lot of interest from WHO. In fact, there's a call for proposals, and there are the TPPs, the target product profiles are out there on the WHO site. And there are two ways to look at it. One is the therapeutic vaccine to treat infection, and one is the therapeutic vaccine to treat CIN. And so they want both of those. And Gates is also very interested right now in this. And they are even looking at scenarios where you give the girl or the lady one therapeutic and one prophylactic in each arm at the same time, and forget about the screening. Whatever they have will get sorted. So that may be the future. So really, sir, thank you for bringing that up. And yes, I met sir at the airport when I was in Bangladesh, and that was very interesting. Actually, they were very committed, and they had invited pairs of doctor and nurse from the PHCs for training. But it had to be a pair because the nurse must get the support from the doctor and training them. And there are many countries where the nurses are doing, Tanzania, Thailand, the nurses are doing colposcopy, the nurses are doing thermal ablations, but our system does not still allow that they do it independently like that. And we need to look at it. We need to downstage.
Madam, one thing I think there's a visual instruction, that is if you make like iodine things, what we are taking the next step. There's a visualization, then you can have the preventive measures. Yeah. That has not been universalized now. What is in your taking from the what you see in the outdoor, that procedure only inspection by colposcopy, see, then putting this is the color changes. That can be the screening methods with AI based and imaging system you can do. That's what we do in the oral cancer.
Yes, that is what is in our program now, the VIA. Actually, VIA was visual inspection with acetic acid and Billy with Lugol's iodine. The Lugol's iodine is much more dramatic. And for health workers, it's really quite easy because the acetic acid brings a lot of shades of white. And is it or is it not and all, but it's more dramatic. But the Lugol's iodine is more expensive and not used in the program. So program is based on the VIA everywhere. Nobody has used the Willy somehow. And in colposcopy, of course, we are still using, but there is definitely a QA issue with the VIA and a lot of false positives. And in the social context, we have seen even in the same village, getting the patients from one part to the other sometimes is the problem. We have to face the fact that in many of these villages, they still have some caste issues, discrimination, and will not go. So we have had to put in the same village, somewhere in the house of the sarpanch, somewhere in the sub-center, in the veterinary hospital, and have several sites. So when I think about mobilizing all these women who will be detected positive by VIA, sending them to a district hospital to get the next step done, assuming we don't have the colposcopy, maybe we have it. And what I worry more about the false positive is that they will go back and say, you know, these people do it, but when you go over there, they tell you there's nothing. So we need a test with a good negative predictive value so that we don't unnecessarily refer and treat. So everything has merit, everything has data to support it. definitely something is better than nothing, and HPV is the best we have.
No, madam, definitely for the audience also, if you will see, this is the CA services going down. One is the educational, second thing after that napkin system, then coming the vaccination. And we are waiting for the Indian vaccination, which will cover like pre-malignant lesions, like 6 and 11 HPV, which will cover the condylomata and the pre-malignant lesions. That will cover the what Indian vaccination is coming by Serum Institute they have taken up, Cervical. They will cover 6, 11, 16, 18. That will be more effective for the Indian things or third world countries. There's if we discuss so many things, this is a never ending for any oncological things. There's thank you so much, madam, for this CS cervix. Anything for the breast cancer? Yeah.
Yeah, I'm Rajiv Tandon, madam. Great presentation as always. I just have one question. With the enthusiastic support to HPV vaccination, Professor N.K. Ganguly mentioned about the budgetary allocations. You mentioned about a couple of states that have taken it ahead. What, in your opinion, is the understanding with pharmacovigilance? And actually, while we were modeling the cost impact of ensuring equity?
Can you just say that last part, cost?
The cost implication of ensuring equitable access to the vaccination, madam, to be able to reach the last lady or the girl that we want to.
See, I think when the government procures in bulk quantities, there will be that will be looked into, and that will be possible, especially with our indigenous vaccine. And the Gavi price for these vaccines has been $5. Of course, the dollar has been steadily rising, so this is not exactly what it was at the time when Punjab did their vaccination. And there was excellent cost effectiveness data generated by Dr. Shankar Prinja, in which he had calculated on the basis that Punjab government used to give 1.5 lakhs per cancer case. That was their expenditure, and the rest had to be out of pocket. Just on the basis of that 1.5 lakhs, forgetting what the patient is spending, forgetting other indirect costs like loss of wages, all those things, only 1.5 lakhs. And looking at the procurement price of $5, which they did through UNICEF at that time, he was able to show that vaccinating the entire district was more cost effective, and they had taken the highest incidence districts to start with, 2 of them. So he was able to show that it was cost effective to vaccinate all the girls at $5 a dose versus giving 1.5 lakhs to each woman who developed cervical cancer. So I think the cost effectiveness data from abroad is definitely there. Some data is there from us also. And the other thing we must not lose sight of is that these women are younger than women with breast cancer, and think it's decreasing the age, but overall the average age of breast cancer and other cancers is more as compared. Years of life lost are more. Children are young, impact on families is more, on communities is more. So I think we have to recognize all these aspects when we talk about cervical cancer prevention, that it's not just the woman that we are saving, it's a lot more than that. But yes, I think the budgetary allocations have kept this in sight. And we have actually more problem from ensuring constant supply chains at this time, plus the wait for the one dose. But I think you will hear good news very soon.
Okay, thank you, madam. And this is the end of the session. Because of the time constraint, we will keep all questions during tea time, because this is a never ending lot of questions which can be answerable, and the queries are there. This way, okay, madam, for one question you can give, this is the last. Sure.
See, when you're doing vaccination for the young girls, same time we can give them the awareness of the palpation of the breast to eradicate or prevent the breast carcinoma. Once they are used to from the school level itself, like early menarche and things, they will get used to in the later life also. I have seen recently a doctor's daughter dying at the age of 32. She never palpated her breast. And when the lump was seen, it was stage 4. So we have to give awareness of the breast examination to the maximum, and we are not finding any money or anything. It is just self-awareness.
Yes, very well said, madam. And they can also take the message home to their mothers and get them to be done. Abhi to we say that it's unethical to do only screening for cervical cancer and not tell them about breast, because breast is more common actually.
breast self-examination, this is a part of this awareness, this prevention. Thank you all, and thank you, sir. Hand it over to the organizer.
Thank you, editors, for this lovely session. And may I now please request Secretary NAMS, Dr. Umesh Kapil, to come on the dais and present a token of respect to our chairpersons for this session. Dr. Umesh Kapil. Thank you, Dr. Kapil. And now I request the chairpersons to, yeah. please. I request the chairpersons to honor our orators for the day, Dr. S. Bose and Dr. Neerja Bhatla. Dr. Bose. Thank you for this lovely session. And today is 65th Foundation Day of National Academy of Medical Sciences. All the members, associate members who have contributed to this great success, now we'll be having a scroll distribution ceremony. And now is the time to encourage, acknowledge, and appreciate the efforts of all the members who have contributed to the successful journey of NAMS. For this, I request Dr. D. Behra, President, National Academy of Medical Sciences, to come on the stage. May I also request Lieutenant General Dr. Velu Nair, NAMS President-elect, to come on the stage for distribution of scrolls, please. Dr. Umesh Kapil. Dr. Umesh Kapil. Dr. Kapil, over to you, please.
Just a minute, 1 minute, please. आप आगे आइए जैसे हमारा I'll call him from the gate and then you will do it. What's the protocol on the left side or right side? Please come from this and do that. You have to build on the sign. शरीर साहब आ रहे हैं कोई नहीं आ रहा है हमारे ऑफिस में वो आ रहा है Namaskar and good evening to all of you. We have the scroll presentation function and I'll read out the names and I request by the serial number they can come over here and we have with us Dr.
Digambar Behra sir, who is our NAMS president, and we have Lieutenant General Velu Nair, who is the president-elect of NAMS. Kindly come and receive your scroll. फोटोग्राफर भाई अच्छी फोटो खींचना सबकी, ठीक है? कहाँ पे खड़े रहोगे? अपनी जगह ढूंढ लो। नहीं, मेरी जरूरत नहीं है यार, मैं देखूंगा नहीं कभी। So we have Dr. Padma Kumar. Dr. Sasi Dharan. Dr. Aishwarya. Dr. Nilashma Singhal. Dr. Shweta Preeti. Congratulations.
Next name.
Dr. Shailata Prisi. Dr. Sudha Sharma. Dr. Brajinder Singh. Dr. Tejaswi. Dr. Nair. Dr. Vasant. Dr. Shreya Sadhu. Dr. Kaul. Dr. Spurti. Dr. Harsh. Dr. Fabaz. Dr. Arju Mishra. Dr. Ritu Singh, Dr. Shobhik Dr. Vandana Dr. Prajwal Gupta, Dr. Swati Jain, Dr. Harshvardhan, Dr. Dinesh, Dr. Sneh, Dr. Richa Sharma, Dr. Shruti Pathak, Dr. Shama K, Dr. Rihina Rishat, congratulations. Dr. Sumit Grover, Dr. Vibha Singh, Dr. Latasha Singh, Dr. Rashmi Sharma, Dr. Abhishek Gupta. Dr. Harsh. Dr. Kartika. Dr. Amandeep Kaur. Dr. Divya. Dr. Jain. Dr. Kunal Kumar Sinha. Dr. Rishi Raj. Dr. Venkatesh. Next. You. Dr. Ashok Sharma. Huh? Do we have any MNAMS member who is present who has not got the testimonial scroll? Or we have any associate member who has not got the scroll? Well, thank you very much. Congratulations to all of you. Some of you have traveled from Kerala, Tamil Nadu, Andhra Pradesh, Assam, long distances. So my congratulations to all of you. You have become part of the NAMS family. which consists of most eminent scientists, medical and biomedical scientists in this country. And we'll ensure that you get all our publications, task force reports, NAMS newsletters, all the circulars of Navigate program. So you're a part of our NAMS family. And please, thank you very much. Now we break for 10 minutes for a cup of tea, which is being served outside. And then we reassemble for the Foundation Day ceremony. Thank you very much.
Okay. All the members present here, please come on the stage for the
हाँ ये बता दो सारे बता दो
कैसे Namaskar, good evening everyone to this special occasion, Evening of Success. It's the 65th Foundation Day of National Academy of Medical Sciences. May I request President NAMS to accompany our honorable chief guest for the evening to the stage. Please put your hands together for our chief guest for the evening. Honorable Minister of State, Professor Satyapal Singh Baghel ji. I would request Dr. Vivek Lal, Guest of Honor, Director, PGI MER Chandigarh, to please come on the stage. And may I request Guest of Honor, Dr. M. Srinivas, Director, AIMS, to come on the stage, please. Please be seated. We gather to honor the remarkable journey of National Academy of Medical Sciences on its 65th Foundation Day. We extend heartfelt welcome to Honorable Chief Minister, Minister of State, Professor Satyapal Singh Baghel ji. Please put your hands together, everyone. Guest of Honor, Dr. Vivek Lal, Director, PGI MER Chandigarh, and Guest of Honor, Dr. M. Srinivas, Director, All India Institute of Medical Sciences, New Delhi. Our distinguished guests, we extend cordial welcome to you all. Today is a great day. It's the evening, a special occasion of success, efforts, and the journey that all of you have come across together and reached this exemplary milestone of 65th Foundation Day of NAMS. We start this special evening with Vande Mataram. May I please request all distinguished guests to stand up in the honor of Vande Mataram, please. Thank you, everyone. Please be seated. NAMS, National Academy of Medical Sciences, is an autonomous organization working under Ministry of Health and Family Welfare. National Academy of Medical Sciences is the premier academy of eminent medical and biomedical scientists in the country. It is a great evening because we have come to the 65th Foundation Day of NAMS. And now for the lighting the lamp ceremony, I request the honorable chief guest and the guest of honors and all the dignitaries on the stage to please come for the lighting the lamp. दीप प्रज्वलन समारोह एक पारंपरिक प्रथा है।
माता सरस्वती शारदा हे माता सरस्वती
Lamp lighting ceremony is a traditional practice that symbolizes transfer of knowledge, wisdom, and illumination of truth. And the same thing is being done by this premier institute, National Academy of Medical Sciences. It is said that if you light a candle for others, it does illuminate and brighten your paths. Similarly, National Academy of Medical Sciences is working for years together for health awareness, supporting and promoting health education. Now, may I request Dr. Digambar Behra, President NAMS, to welcome and felicitate Honorable Chief Guest, Union Minister of State, Professor Satyapal Singh Baghel ji, by presenting a token of respect to him. Ladies and gentlemen, please put your hands together. It's a great evening, great moment, a journey of success that all of you have been the part of this journey. With your great efforts, NAMS has become a great achiever, completing 65 years of excellence. I request Lieutenant General Velu Nair, President-elect NAMS, to welcome Dr. Vivek Lal, Director PGIMER Chandigarh. Please put your hands together, everyone.
Thank you so much, sir.
May I now please request Dr. Neerja Batla, Vice President NAMS, to welcome and present a token of respect to Dr. M. Srinivas, Director AIMS, guest of honor for the evening.
आप इधर बताओ ना।
Thank you, Dr. Neerja. So without further ado, let the celebration begin. Sit back and immerse yourself in the spirit of NAMS as we embark on this unforgettable journey together. NAMS, National Professional Organization that honors medical scientists, supports and promotes medical education in the country. The new initiatives include fellowship programs in northeastern states, Jammu and Kashmir and Odisha for young faculty and PG students. कहते हैं हौसलों से मिलता है सफलता का मुकाम, आसान नहीं है दुनिया में कमाना अपना नाम। नेशनल एकेडमी ऑफ मेडिकल साइंसेज ने न सिर्फ सफलतापूर्वक इतने वर्षों से कार्य किया है, नाम कमाया है, इन बुलंदियों तक पहुंची है कि आज हम 65th फाउंडेशन डे के अवसर पर एक साथ यहां उपस्थित हैं, उसको सेलिब्रेट करने के लिए। I now request Lieutenant General Velu Nair, President-elect NAMS, to deliver the welcome address, please.
A very good evening to all the esteemed guests, the NAMS council members, and the entire NAMS family members, ladies and gentlemen. It's indeed a great pleasure to welcome you all to the 65th Foundation Day of the Academy, which is a celebration of achievements of the Academy and dedication to promote continuing medical education for both medical and allied health professionals and to support policy initiatives in the country. On this special occasion, we are very honored to have with us our chief guest, Professor Satyapal Singh Baghelji, the Union Minister of State in the Ministry of Fisheries, Animal Husbandry and Dairy, and the Minister of State in the Ministry of Panchayati Raj, a highly qualified and distinguished politician who has many qualifications. And what pleasantly surprised me, sir, was that you are an MSc in military sciences. And actually that comes something which is, very familiar to us. LLB, PhD, MA in history. He has a long, distinguished political career of over 3 decades, holding just about all important positions that you can think of. He has served 5 terms as a member of parliament, as a member of the Legislative Assembly of Uttar Pradesh, whereas a cabinet minister of livestock, minor irrigation and fisheries in the government of UP, Minister of State for Law and Justice in the Union Cabinet from 21 to 23, Minister of State for Health and Family Welfare again in the Union Cabinet from 23 to 24 to the present position which I have just announced. He has made valuable contributions as a member to many important committees on subordinate legislation, human resource development, health and family welfare, food, civil supplies, public distribution and undertaking, external affairs, and a member in attendance of the House. We are particularly grateful for your presence, sir, for you to share your insights and experiences with us. And we are sanguine that your presence will greatly enrich this event and provide us valuable learning opportunities for all. I now have the privilege to extend a warm welcome to our guest of honor, Professor Vivek Lal, Director, PGI Chandigarh. Dr. Lal is an eminent neurologist who has done pioneering work and has actually established the entity of ophthalmoplegic migraine in India. And he's credited with the largest series in world literature on this subject and has numerous national and international publications to his credit, besides various chapters and awards. The grand rounds which he conducts has been extremely popular with his students, and I'm not surprised he's been awarded as a master teacher as well. He's lectured all over the world, including different world congresses, and always kept the PGI flag flying, and obviously with it, the national. He strongly believes in holistic medicine and is the chairperson and heads the committee of yoga medicine and integrative medicine in PGI. And he's been organizing a large series of lectures, seminars, campaigns at the community level and striving to remove the societal taboos which go along with certain treatable or otherwise neurological disorders. Sir, your presence today is of immense inspiration to all of us. Now, on behalf of the NAMS Council, I would like to welcome our distinguished guest of honor, Dr. M. Srinivas, Director, AIMS, New Delhi. He doesn't need much of an introduction because he's very closely associated with NAMS. And over the last 1 year, at least, I'm seeing that he's really associated with us and, has been really supporting the NAMS activities. Thank you, sir. He is an eminent pediatric surgeon with an illustrious career behind him, spanning over 3 decades, holding various positions in academia, administration, and on the research fronts. He's done a prestigious fellowship from the Children's Research Center in Dublin, Ireland, and came enriched back to pass it on to his students. Professor Srinivas joined AIMS in 1994 and rose steadily to become the professor of pediatric surgery in the year 2001. And currently, he holds the prestigious appointment of Director AIMS since September 2002. His yeoman contribution in the medical field doesn't stop there. He's developed new medical colleges, ESICC Medical College at Hyderabad, Beta Bihar, and in Alwar, Rajasthan, besides 7 other such medical colleges in the state of Telangana. That's humongous. Professor Srinivas has made great contributions in AIMS since he's taken over towards development of new units, specialties, lab facilities, and programs for advanced therapeutics and diagnostics. He has been an outstanding career student throughout his career, actually earning a lot of awards and gold medals. And he's a distinguished member of multiple professional organizations, 15 to be precise. And with that come numerous fellowships. Sir, we are truly grateful for your time and commitment to NAMS. I now extend a warm welcome to all the senior officers from the Ministry of Health and Family Welfare, all the Institute of Medical Sciences, other medical colleges and academic institutions, NAMS fellows and members, eminent medical and biomedical scientists, presidents of various national and professional organizations, principals, directors, deans, faculty members, guests, and the media, and not the least, the press. And of course, no such meeting is complete without students. We could do with some more. Your blessings and presence this evening with us on our 65th foundation celebrations is indeed a source of encouragement for the whole of the National Academy of Medical Sciences. Thank you very much. Jai Hind.
Thank you, Lieutenant General Velu Nair. Feel the heart and the soul of NAMS to reminisce about the moments that have shaped us and to celebrate the milestones that have propelled us forward. कौन कहता है कामयाबी किस्मत तय करती है? कौन कहता है कामयाबी किस्मत तय करती है? इरादों में दम हो तो मंजिलें भी झुका करती हैं। नेशनल एकेडमी ऑफ मेडिकल साइंसेज ने अपने हर प्रयास से और आप सभी के प्रयासों से न सिर्फ विश्व में ये स्थान प्राप्त किया है, बल्कि एक सफलतापूर्ण सफर भी तय किया है। Dr. Digambar Behra, President NAMS, who is taking care of the responsibility of this organization as of now. He is Director, Pulmonary Medicine, Fortis Healthcare, a world-renowned chest physician, ex-director, National Institute of TB and Respiratory Diseases. He was fellow American College of Chest Physicians and Asia Pacific Society of Respirology. May I request Dr. Digambar Behra to tell us more about the present activities, vision, and the way forward, the futuristic approach of National Academy of Medical Sciences.
Honorable Chief Guests, Sri Bhagalji, Honorable Union Minister, Professor Vivek Lal, Director, PGI Chandigarh, Professor Srinivas, Director, AIMS, New Delhi, General Velu Nair, the President-elect, Professor Nirja, the Vice President, Professor Umesh Kapil, the Secretary, NAMS, the former presidents of NAMS, Professor Ganguly, Professor Talwar, Professor Chudamani. Actually, two of them are my respected teachers, guides, and mentors for whom I am here today. I am grateful to you, sir, and I am very much honored for your presence today as my first presidential address to this August gathering. Then senior fellows, I could see Professor G.P. Talwar, the esteemed members of the Executive Council of NAMS, there are a number of them here, the fellows, the members of the National Academy, other family members of NAMS, ladies and gentlemen. At the very outset, I congratulate you all on behalf of the NAMS on the 65th annual Day of National Academy of Medical Sciences. You all know that National Academy of Medical Sciences is a unique institution which fosters and utilizes academic excellence as its resource to meet medical and social goals of the country. Its evolution started in the year 1960 when the resolution that runs as follows: the Central Council of Health, having carefully considered the views expressed by the state governments, universities, and professional organizations on the proposal for the setting up of an Indian Academy of Medical Sciences. It welcomed the proposal for the establishment of an All India institution with a view to bring on a common forum the best talent in the field of medical sciences in India. Sri D.P. Karamkar, the then Union Health Minister, expressed that eminent Indian medical scientists, instead of looking for a recognition outside the country, should be honored and their merit should be recognized in the country itself. The Academy was registered on the 21st April 1961 with the registrars of societies as the Indian Academy of Medical Sciences. The Memorandum of Association was signed by eminent scientists like Dr. V.K. Anand, Lieutenant Colonel Sangamlal, Dr. V. Ramlingaswamy, Dr. K.L. Wig, Colonel B.L. Taneja, Dr. R. Viswanathan, Colonel Amit Chand, and Dr. Sen, etc. The vision of the NAMS was and still is to act as a think tank for policymakers in all spheres of health, including medical education, research, for cost-effective healthcare to help the humanity at the national and international level. Its roles and responsibilities are very clear: to promote knowledge of biomedical sciences in India and its application to problems of national health and welfare, to recognize and encourage merit in all branches of biomedical and allied sciences, and to confer distinctions, awards, and such honors on fellows or officers and others commensurate with their achievements. Again, to undertake biomedical scientific research of national and international importance, and to assist the government of India and its agencies in framing policies and programs on biomedical and public health issues. And lastly, promoting medical education by conducting CMEs in medical institutions throughout the country and many others. It was, as I told, it was registered as the Indian Academy of Medical Sciences this day in 1961, about 65 years back. It was inaugurated at New Delhi on the 19th of December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The first convocation of the Academy was held on the 8th of December 1963 at Vigyan Bhavan, New Delhi, and the convocation address was delivered by none other than Dr. Sarvapalli Radhakrishnan, the then President of India. The Academy was renamed National Academy of Medical Sciences, India, on the 16th November 1976 on the recommendation of a working group set up by the Government of India. The uniqueness of the Academy is that, unlike many other professional societies or associations of various medical specialties, this Academy consists of all branches of medical sciences of all categories and specializations, and functions as an autonomous body where only excellence and achievements matter. Who's who of all branches of medical science, whether clinical, paramedical, or basic sciences, dental sciences, and other scientists are part of this august body. The best medical brains of the country are part of this academy and are available with expertise and years of vast and rich experience in clinical care, research, medical education, formulation of policies related to health and medical administration. More than 60 of its fellows are various Padma awardees, including Bharat Ratna, Padma Vibhushan, Padma Bhushan, and Padma Shri, etc. Thus, the NAMS serves as a great stock of human resource in the field of health who are ready to help the government in particular and the people of India in general. Only the government has to ask for them whenever and wherever it wants them. I will present before you, ladies and gentlemen, a brief academic activity of NAMS during the past years. The Academy confirms fellowships and memberships selected through a rigorous peer review process. Every year, not more than 60 are enrolled into the fellowship program. Earlier, it was only 30. As on date, the Academy has more than 1,000 fellows, 5 honorary fellows, 2,562 members, that is the MMS, 75 associate fellows, and nearly 10,000 members by DNB, that is MNAMS. Strict objective criteria have been introduced for assessment from the year 2023. We have provision for NAMS international fellowships and international membership, and applications are invited from medical doctors and scientists who are nationals of foreign countries, NRIs, OICs. Then the NAMS Council awarded 4 international fellowships and 1 international membership during the year 2023 and 2024. In fact, this introduction of this international fellowship was the brainchild of our past president, Professor Sarin. Then the NAMS membership is given to Indian scientists of eminence from any field of basic sciences, medicine or surgery, or biomedical sciences with postgraduate qualification and a minimum of 5 years of experience after post-graduation. To encourage the youngsters and to make them part of the NAMS family, the provision for NAMS Associate Fellowship and a NAMS Associated Membership have also been introduced. And I have already commented about the NAMS membership given to the DNB past candidates. I think again I remind the August gathering that when we started the DNB program in the country, the responsibility was given to this National Academy. Then subsequently, we had the National Board of Examination. Then the NAMS supported CMEs. The Academy has been recognized by the Government of India as a nodal agency for promoting continuing medical education for medical and allied health professionals. The NAMS encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical discipline. Financial assistance in the form of grant in aid for holding CMEs is provided to the institution based on the application received as per the guidelines. So last year, we have provided this help to 29 institutions from all over the countries, and we have held 43 CMEs that year only. Then the joint AIMS NAMS Navigate Medico CME program in collaboration with the 16 All India Institute of Medical Sciences with the lead role of AIMS New Delhi. I have started the joint AIMS NAMS Navigate Medico CME program for postgraduate medical students. This year, from this year onwards, the director PGI had kindly agreed and to be part of the system, and now we have named it as AIMS NAMS PGI Navigate Medico CME programs. So far we have done total 18 such programs. Then the NAMS Navigate Medico CME, this was launched on 22nd January 2023, again a brainchild of Professor Sarin for the PG students. As on date, 41 such sessions have been held. Now then we have the other facilities like API NAMS Online CME. Then the leadership development workshop by NAMS is another newer initiative. We know that we doctors mostly, we are mainly interested in the academic activities, but when it comes to the leadership role, our training during our curriculum is not usually imparted like the other forms of services. So it was thought that we should train our senior persons like heads of departments, medical superintendents, and others, so that they take leadership roles, and it is a very popular program that is being undertaken by NAMS. Then the networking with medical colleges and institutions from time to time. We have networking with all the above 700 medical institutions of the country. We network with them. Then the national quiz for MediQuest that have already been done, 2 or 3 has already been done. Then the NAMS virtual library, then the NAMS state chapters, and then the establishment of NAMS units in medical colleges and institutions. 35 such cells have been already established in various medical colleges and institutions. I think another initiative that has been taken is the NAMS statistical helpline for the postgraduate students. It was realized that statistical help is a very essential component for our PG students, and many colleges and institutions in the country, they do not have this facility. So to facilitate both the thesis and other research work, around the clock, this online statistical helpline is established so that anybody can contact and get help. Then the NAMS faculty members, we have got the council has decided to have a faculty mentors. So 84 faculty members from medical colleges and institutions have volunteered to act as NAMS faculty mentors. Then again, we have got to encourage our retired professors. We have got the system of NAMS emeritus professors, and we have got so far 38 such emeritus professors who provide guidance and mentorship to various institutions to develop specialty or laboratory services with newer technologies or services in medical and allied sciences. Then the preparing policy documents for policymakers and for advocacy with the stakeholders. The NAMS has constituted so far 22 task force of eminent medical professionals from government and private organizations, as well as the representative from the Ministry of Health and Family Welfare to prepare policy documents to provide a critical review. So many of these, the documents have already been published by our annals. They're submitted to the government, and now we are planning to have, dissemination of these workshops in different parts of the country. Then to become a part of the consortium of national and international academies, professional societies, and both the government and private institutions. Then we have started as a partnership, as a certificate course. In fact, we are a partner to a certificate course on artificial intelligence with the Triple IIT Hyderabad, and the course has already been started, and we are very soon going to start the third session, and the MOU with them has been started. Then the academy has started the academic recognition of various faculty, medical, dental, and other biomedical sciences, and 24 such academic recognition will be done from this year. You all know that the awards which were given earlier have been, banned by the government of India. So we have started this academic recognition from this year. And then we recognize our women scientists who have achievements. So these are some of the activities that NAMS has or is undertaking. Then the next point, I'll just take a few more minutes. So what is the way forward for NAMS? While the academy proudly continues to fulfill its mandates over the past 65 years, it needs to reorient its role as envisaged by its forefathers, leaders of the country and its leading lights. There are certain unfulfilled missions of NAMS that needs to be carried out and completed. As the mission of NAMS, I read out to you to act as a think tank for policymakers in all spheres of health, including medical, education, research, for cost-effective healthcare to help the humanity. Although many individuals and fellows of the academy have already contributed and contributing their bit in all these three aspects in one way or other, the NAMS as an organization need to project and provide its views, suggestions, and the way forward on these three aspects of health: medical education, biomedical research in India, and the healthcare delivery system. We have just discussed today morning in our council meeting how to go about these issues, and we need a definitive roadmap to suggest to the government and various executing bodies like the National Medical Council, National Board of Examination, Niti Aayog, and various state authorities and medical and dental institutions in the country. The country has made tremendous improvements in medical education, wherein more than 700 medical colleges are now available in the country, both in the government and private sectors. What is the quality of medical colleges? What is the quality of teaching and clinical training to our future doctors? Have we got sufficient number of qualified medical teachers? It needs a thorough discussion and analysis. NAMS has a huge number of experienced fellows, a huge human resource, and a large think tank with years of experience that can be utilized by the system. Biomedical research is another important issue that needs a thorough discussion. We need to develop our research capacity of the huge number of faculty available in over 700 medical colleges and DNB institutions. Just imagine if we take out at least one good quality research idea or a research question or a research paper per faculty every year, what will be the number every year from our country? NAMS will be ready to train them in teaching and research methodologies through various means like workshops, symposia, and online training, etc. Healthcare delivery system in the country is one of the best in the world today with introduction of various schemes by the government. But we should always remember that there is always a need for the better than the best. Now, new innovations and delivery systems can be worked out. Its senior and experienced fellows can be useful to extend societal outreach program wherein patients can get their second opinion online or through various telemedicine systems or through other e-health systems. Immediately, we will plan to start teaching and training modules for the medical caregivers and other paramedical staff like nursing and technicians through our national health mission schemes. There are great expectations from the academy by various great leaders of the country, and you can gauge the importance of the academy from few of the quotes I am going to narrate here. For example, Pandit Jawaharlal Nehru, the first Prime Minister of India, in his inaugural address on 19th December 1961 has said that I quote, "I hope the Academy would lay stress on the pursuit of research work and simultaneously ensure that high standards are maintained. Research is an inseparable part of any systematic pursuit of knowledge, and therefore it is imperative that the quality should be absolutely first class." The Sarvapalli Radhakrishnan, during his convocation address, had said that, but in the choice of your fellows, be careful, be vigilant, take care of the great reputation which you should enjoy among the sister academies of the world. Then Srimati Indira Gandhi, the Prime Minister of India, on the 6th convocation address on 6th December 1968, had said, an academy such as this, one should be able to do great deal to maintain and to raise the standards of the medical profession and also to give direction and purpose to the activities of members aspiring to the distinction of joining your rank. So many great people actually throughout these years, because of lack of time, I'm not going to read every one of them, but everybody had high expectations from the academy, and I think the academy should be able to fulfill these aspirations of these great leaders and also of the country. As you can see, stakes are very high, and there is a lot of expectation of the country from NAMS. We are just going to finalize the vision document of the NAMS for the next 5 to 10 years, and a group of eminent and senior fellows are working on this. After the final recommendations and the discussions and decision by the Executive Council, we will work more aggressively to achieve these objectives. The physical expansion of the NAMS with addition and construction of a new block that was envisaged long ago also needs to be revived. We will also try to become self-sufficient financially to expand our activities, for which we will need cooperation from all. May it be corporate funding, contribution by fellows and other donors, and the ministry, or through other activities, we will try to improve our financial position. I will end my presentation with a quote from our beloved Dr. Abdul Kalam, that is, dream, dream, and dream. Dreams transform into thoughts, and thoughts result in action. You have to dream before your dream can come true. What is most important is to look ahead to the future, to think of the next generation. The entire team of NAMS, including its Learning Council members, is striving to tread new paths and guiding and working hard to take the academy to greater heights. On this 65th annual day, ladies and gentlemen, I wish to thank the council members, fellows, members, and well-wishers of NAMS for their commitment, continued support, and advice. Jai Hind.
Thank you, Dr. Behra, for taking us through the glorious journey of National Academy of Medical Sciences and highlighting the great efforts that are being done by this academy. And today's guest of honor for this evening, Dr. M. Srinivas, Director, All India Institute of Medical Sciences. He had an illustrious career with more than 3 decades of experience in various positions in academic, administrative and research fields. कहते हैं, सफलता की पोशाक कभी तैयार नहीं होती, इसे बनाने के लिए मेहनत का हुनर चाहिए. The kind of positive changes he has made in the working pattern of All India Institute of Medical Sciences, that is the very point he is appreciated and admired by most of the faculty members. Dr. M. Srinivas, please.
Sorry, cut short. Good evening to everybody. Professor S.P. Baghel sir, you are always fondly as our minister. You know, हम तो अभी भी सोचते हैं कि आप हमारे minister हैं. Professor Vivek Lal ji, Professor Behra ji, Professor Umesh Kapil ji, Professor Velu Nair ji, Madam Professor Nirja Bhatla. The one good thing which makes us happy here is, you know, of all the things, NAMS, activities and everything, you see people from Professor G.P. Talwar, and of course, there is Talwar there. Everybody's here, 4 generations. I think give a big hand to the organizers who have brought us 4 generations of people. Teachers, teacher. I can, the genetic pedigree of their medical education and the great teachers of this country I can see today. I'm extremely happy that, you know, I'm able to see those people here. This is something which gives us the feeling that, you know, we have been having the legacy of the great doyens who are sitting here. Well, I don't want to go into much of the details. They have given 4 pages of talking points. We'll not go into that, except to say that, sir, we are here to assure you from the All India Medical Sciences that whatever the activities which you are taking up, for example, the Navigate Medico CME, which you are doing with AIMS, now with the PGI, we continue to be there, you know, because we feel that it is our duty to be handhold this institution, which are just across with each other, and do whatever the best we can do it for the people, especially the youngsters. The biggest gap which I see here, you know, you look at the average age of the people who are sitting here, and actually what is the average of the doctors of the country? There's a huge gap. Somewhere we need to connect that, you know, somewhere we need to connect the young people. The best way to connect the young people is look into their needs. There are needs of those people, because those needs are not being either given by us, or it has not been given the way they want us, or there is something which we need to look into that and then find out. You know, that's where we have to do it. It's such a wonderful organization. You know, when the National Academy comes into the mind, we think of the National Academies of USA and various countries. You know, we have seen all of them. And that is something which we need to look into that. You know, all the doyens are here. Somewhere, I think, sir, give a helping hand to the people, which you are giving it. We are going to be part and parcel of that. I'm not saying that we are not giving it. We need to look into that how best we can give more helping hand to the people and bring them into this fold. And this has been happening. You know, there's a lot of thinking happening. Sir has called up many times that, you know, Dr. Srinivas, batao kya karna padega iske liye? What should we do? You know, we have discussed some time back on that aspect. So the Navigate Medico CME is one which is very good, which has happened. Many people are getting connected with the national board, the NAMS also. The state chapters which you have created, again, the connect which is required between this organization at the federal level and also at the state level. A very good work has been done. This is something which will go a long way in consolidating what we have done. The Honorable Minister was asking ki, what are the contributions? You know, I was just talking about the great contributions the NAMS has done. I said, sir, जो भी यहाँ से पद्मश्री रॉय, पद्मश्री, भारत पद्म विभूषण मिलता है, सब यहाँ से मिलते थे. I just summarized to him and said that, you know, that's what was the NAMS. So those things has to come back, whether it is a national health policies. You know, I see that, you know, 23 task forces have been created. Sir, let me assure you again, from the bottom of the heart, that we are from the AIMS faculty, we are with you for whatever the things which you want to do in the task forces, policy, advocacy, whatever the support which you want from us, we will definitely take it forward. And with respect to the index journal which we have, contributions from the people, you know, the best way we can actually make it into one of the best or the indexed art, the journal is getting the contributions of the people. We all have, we have AIMS here, we have PGI here, we have all the people here. The best of the articles which can come to the NAMS journal rather than to others in whatever capacity. It could be a CME, it could be a national conferences, especially focused on that, so that we can move forward and say that, this is one of those best journals which we can have in our country. And then the domains which we talked about, Sir talked about the domains of the teaching, learning, and the research and administration, and the dual degree or consolidated degree. Basically, we are complementary. The NAMS is complementary to whatever the things which are happening. We continue to consolidate those things and then take it forward. And whatever the aims can do, we are with you. And when I look into that, when Professor Behra spoke in depth about not only the genesis, the history, the legacy of the NAMS, the various activities which are envisaged, all that, I only assure you that, we stand by you, and definitely will take part on all the activities which we want to take it up. And today, there's a big issue for us. I think all the doyens are here. Professor Talwar will agree with me that, we need to look into that. Where are the standards? Can't we have a uniform medical education standards? That's where the gap can be filled up from the NAMS. We have a spectrum of the medical colleges, 700 plus medical colleges in the country. Some of are excellent, some of are struggling to get in. But the problem is the medical colleges may be struggling, but what happens to the medical students? Is there any organization which can handle them? I think that's where the NAMS is doing it. The CMEs started by Sir is something which is helping all of them to get back to the medical education domain, teaching, learning domain, whatever the best which we can do in a national platform, so that the best of the people from AIMS, PGI, different institutions of this country will go on board and then handhold them, speak to them, teach them, make them learn the things, and then ask them to do research. Again, that's the problem with our medical institutions in the country, where a small segment of the things are not focusing on the research. We need to look into that, and that's where the NAMS and AIMS and the PGI Chandigarh will definitely taking part and handholding to you. The other thing is that we have a silo problem, we do not collaborate. That's where the doyens are sitting here. And it's a time where these doyens will speak to the people and try to collaborate between the institutions, the best of the institutions of the country, the best of the basic sciences. See, the advantage of the NAMS is the spectrum. You're a spectrum. You're not a medical domain person. You're not just medical. You're medical, dental, nursing, paramedical, biomedical, basic sciences, everything is under the spectrum. That's where we need to connect those dots, because we are becoming more and more, less collaborative, and that doesn't going to help us, because a lot of money is going to these medical institutions. And unless and until we collaborate with the people across the board, medicine to the dental, paramedical, basic medical sciences, different institutions of the country, and the doyens has to tell, the people who are sitting here that, please break that syndrome, my syndrome. The problem with us is today is it's my lab, my equipment, my unit, my PG, my PhD. Please help us. There are doyens sitting here. Break these silos and help the people. Tell the thing, the knowledge and the wisdom to the people that they should be collaborating to the people. That's where we can do wonders, because I see the NAMS is doing a lot of good work, especially in artificial intelligence, digital health. A lot of activities have started. Connect to the young. That's where something which we need to look into special focus, that how are we going to get those people on board? How are we making them to sit in this institution when these kind of activities are happening? How are they going to connect to the people who are there here so that they can continue with the teaching, learning activities and research and administrative roles? A lot of things are there. So this, we should not just become honoring people, giving the fellowships and the honors, think tank or policy advocacy, but I think we have to take up, which they have taken up, but we need to consolidate and complement and come out in a big way. And we stand by, at least from the AIMS and from the PGI, sir, will definitely assure you and guarantee that, we are committed to be part and parcel of joining hands for your teaching, learning, research, and administrative activities. Let us work together. That's what the mantra which I want to carry to the people. Let us work together, cutting across all these domains and the institutions. Only you can bring, who will listen to these people, only you can do, because you are our teacher. You have that kind of the powers to tell to us, the young generation, that, let us sit together, think together, work together, and come out of the silos and say that together we can achieve more for building the nation, and then be part and parcel of the Viksit Bharat. This is what I just wanted to share with you. Thank you very much. Jai Hind.
Thank you, Dr. M. Srinivas. And now I would request guest of honor, Dr. Vivek Lal, Director PGI-MER, who he is a great medical expert, and his presentations, especially the grand rounds, are extremely popular among the students, and he has been awarded with Master Teacher Award. He believes in holistic medicine and is the chairperson of Integrative and Yoga Medicine. सफलता पूर्णता कड़ी मेहनत और असफलता से सीखने, निष्ठा और दृढ़ता का परिणाम होती है, और इसी के एक उदाहरण हमारे साथ हैं डॉक्टर विवेक लाल. प्रोफेसर विवेक लाल, प्लीज.
Honorable Chief Guest, Shri Baghel ji, my friend Professor Srinivas, Professor Digambar Bera, Lieutenant General Velu Nair, Professor Neerja Bhatla, Professor Umesh Kapil, distinguished and colossal personalities of the dais. I'm honored and privileged to be part of this function. To me, NAMS represents everything good about Indian medicine. I do not know of any other organization, private, public or otherwise, in India, which can boast of 60 Padma awardees, more than 60 Padma awardees. I think this is a huge feather in the cap of NAMS. Not only that, more than 5 of them have got the Bharat Ratna also. But having said that, I think today we need to look beyond what we have achieved. As Professor Bera was pointing out, our great visionary Prime Minister is trying to promote health for all and has given a clarion call for a Viksit Bharat. Now we have to integrate the vision of NAMS with that of a Viksit Bharat, keeping that in mind. We were talking about silos. I fully agree with you. Our nemesis has been working in silos. AIMS doesn't look at PGI, PGI doesn't look at AIMS. That's for sure. Professor Talwar was a common factor when he came as director and he took PGI to another level. Thank you so much, sir. But I think, sir, having said that, it's important now that when the government has decided to breach the limit of 1 lakh medical students, we need to have a look at one very honest issue. Are those medical students the real raw material which should be there in these medical students? The answer is an emphatic no. The answer is an emphatic no. Let's be honest, we are Indians. We need to do a lot of hard thinking. And for that, I think organizations like NAMS, organizations like NMCs, other Government of India organizations need to put our heads together, because ultimately what we are today is because of our teachers who taught us. What we are today is because of the values that they gave us. What we are today is because of the hard work and commitment that they instilled into us. When Professor Talwar was the director of PGI, I never slept. 1 o'clock at night, I would get a call. 2 o'clock at night, I would get a call. And I was there in the hospital in 15 minutes. But Dr. Talwar was already there. So these are some of the values that we need to actually inculcate. We're talking of high-tech research. High-tech research is very important. All that is good for the sake of optics, for the sake of playing to the gallery, but we need commitment. If we don't have commitment, high-tech research has no meaning. I mean, there's no point having a resident who's sleeping on the side of a ventilator. Unfortunately, that is what is happening. That is what is happening. And we need to stop this and stem this rot. For that, we need to really get down to operation brass tacks. We need to pick up our residents. We need to tell them to pull up their socks. We need to be harsh for their future. We need to be hard to ensure that they have a soft landing later on. Otherwise, my worry is all this will be a dream. all this will be a dream. There is no doubt that the best corpus of medical talent is in India. Let me tell you that. Any Indian who goes abroad, the president of the American Nephrology Association, an Indian from PGI, the president of the Global Nephrology Forum from India, a PGI, a president of American Academy of Neurology, PGI. And Dr. Chopra कहते थे तो खोटा सिक्का, he is not fit to be in India. There he went on to become the president of the American Academy of Neurology, Professor Kapil Sethi. I still remember Professor Kapil Sethi when he came to PGI. Professor Chopra कहते गधा आ गया. But that Gada was the president of the American Academy of Neurology. And that is the talent that we Indians have. And I think we need to understand one thing, that this talent will soon get wasted. I happened to go to AFMC, General Velu Nair. I just happened, it's my habit, I talk to students in the corridor. I said, which book of pathology did you read? So they looked at me and they said, Marrow. I said, I almost had a heart attack. Marrow, I said, wo kaun si kitab hoti hai? I thought AFMC is brilliant. I thought it's the best college because my father taught there and I wasn't selected for AFMC, right? And so I thought that these guys are going to tell me, these are the 10 books that we read. And they said Marrow. They didn't know the name of Robbins. My basic aim was to ask them, who's the editor of Robbins? He's an Indian, Vinay Kumar. He's from Amritsar Medical College. So that's what I wanted from them. And they said Marrow. Now, if this is the status and this is the state of affairs of what the future has for us, then, sir, we are going down a cliff. We have to stem this rot. We have to stop this rot. Whether you are director of AIMS, whether you are director of PGI, whether you are professor emeritus, until we do not stop this rot, the purpose of these organizations will not be achieved. I've been honest, I'm sorry, but I am genuinely concerned as much as Professor Srinivas about this generation which is coming into medical care and whose only aim, unfortunately, is ये मैं 5 साल के बाद MBBS करके यहाँ जाऊंगा, इतना कमाऊंगा, यहाँ जाऊंगा, इतना कमाऊंगा, यहाँ जाऊंगा तो बहुत कमाऊंगा. That freedom of thought which we have given them is now being governed by lucrative principles, not by intellectual principles. That is where, sir, NAMS needs to take its role. All organizations concerning medical care need to move forward as one so that we can get our boys and girls who are brilliant, who are misguided, and who are falling prey to undesirable activities to really come into the fold of our teachers who gave us the values and who are still lighthouses of knowledge and spiritual strength for boys and girls like someone else. Thank you so much. Namaskar. Jai Hind.
Thank you, Dr. Vivek Lal, for this insightful address. कहते हैं सफलता का रहस्य एक दिवसीय नहीं होता, यानी एक दिन का नहीं होता, उसके पीछे कई कठिनाइयां होती हैं. Today we'll honor all those who have contributed to National Academy of Medical Sciences to bring it to this level, to this stage, and completing this milestone. For this, may I request all the dignitaries on the stage, honorable chief guest, guest of honors, and esteemed dignitaries. For the first honor, I would request Dr. G.P. Talwar to come on the stage. Dr. Gurusaran Pran Talwar is a medical researcher working in the area of vaccines and immunocontraception. He was head ICMR WHO Research and Training Center in Immunology for India and Southeast Asia. He was professor of eminence and senior consultant, International Center for Genetic Engineering and Biotechnology, New Delhi. Visiting professor, College de France. Welcome Professor Johns Hopkins and distinguished professor at the Institute of Bioinformatics and Biotechnology, University of Pune. So please come. We are privileged and honored to have you here. Please put your hands together for Dr. G.P. Talwar.
I'm 98 years old.
Dr. G.P. Talwar's energy is exemplary for all of us. Please put your hands together for Dr. G.P. Talwar. I would request eminent scientist, Dr. K.K. Talwar, who is a medical professional, professor and head Department of Cardiology, All India Institute of Medical Sciences till 2004. Director, Professor and Head, Department of Cardiology, Postgraduate Institute of Medical Education and Research, Chandigarh. Chairman, Cardiac Diseases, PSRI, Heart Institute, New Delhi. So please come on the stage for the honor. Please put your hands together for Dr. K.K. Talwar. May I now request Dr. N.K. Ganguly, former Director General, ICMR, formerly President of Jawaharlal Institute of Postgraduate Medical Education and Research, former Director General, Indian Council of Medical Research. He has been honored with the prestigious Padma Bhushan. Dr. Ganguly. I now request Dr. Saroj Churamani Gopal, an Indian medical doctor, medical educationist, considered as the first woman in Master's Pediatric Surgeon from All India Institute of Medical Sciences, New Delhi. The Government of India conferred the Dr. B.C. Roy Award to her and followed by Civilian Award of Padma Shri. Dr. Saroj Churamani. Big hand for her, please.
He not says he's already doing a enroll for PhD. Now it's
Thank you, esteemed guests, for these honors. Please be seated.
I think I got a message today that just now, one Professor Ramaswamy from he's doing celebrating his 100th birthday today. So I think on behalf of the NAMS, we send his best wishes.
And the Honorable Chief Guest for today, Professor S.P. Singh Baghelji, Minister of State for Fisheries, Animal Husbandry, Dairying and Panchayati Raj. He has a glorious career and has done great efforts. कौन कहता है कि सपने कभी पूरे नहीं होते? हिम्मत वालों के हौसले कभी अधूरे नहीं होते, जो लिखते हैं पसीने की स्याही से अपने इरादों को, उनके मुकद्दर के पन्ने कभी कोरे नहीं होते. Put your hands together for our honorable chief guest.
नेशनल एकेडमी ऑफ मेडिकल साइंस के 65वें स्थापना दिवस के इस अवसर पर मंच पर विराजमान डॉक्टर वेलू नायर साहब, श्री दिगंबर बेहरा साहब, विवेक लाल जी, डॉक्टर श्रीनिवास जी, डॉक्टर नीरजा, डॉक्टर कपिल, और उन सब से ऊपर प्रोफेसर गोंगली, प्रोफेसर तलवार, 2 तलवारें हैं शायद एक म्यान में, तय करो बड़ी कौन सी है छोटी कौन सी. प्रोफेसर चूड़ामणि, डॉक्टर सलीम साहब अभी भी गए हैं हमारे बीच में, काउंसिल मेंबर्स, देवी एवं सज्जनों. वैसे ये कहा ही जाता है कि मेरा सौभाग्य है कि मैं लिखने वाले भाषण यहीं से लिखते हैं. इट्स माय प्रिविलेज टू अटेंड दिस. लेकिन वास्तव में मेरे लिए सौभाग्य की बात है, नाम्स जैसी संस्था के 65वें स्थापना दिवस पर मुझे आने का मौका मिला. भगवान धन्वंतरी के मुकुट के तमाम नगीनों के दर्शन करने का अवसर प्राप्त हुआ. चिकित्सा के आकाश के बहुत सारे सितारे को देखने का और उनको अवार्ड देकर के खुद अपने को सम्मानित कर रहा हूं, ऐसे लोगों को अवार्ड देने का अवसर प्राप्त हुआ. मेरे जन्म के साथ ये संस्था की स्थापना हुई और अब 65 साल की हो गई. सीनियर सिटीजन से भी ऊपर सीनियर हो गई. लगता है इसके बुनियाद, स्थापना दिवस पहले के बुनियाद के पत्थर बड़े मजबूत हैं. जो 65 मंजिला इमारत आज तैयार है और हर मंजिल पे ऐसे लोग रहे कि ज्यादा डेंटिंग पेंटिंग की इस इमारत को जरूरत नहीं पड़ी. उन्नीस सौ 61 नेहरू जी, सर्वपल्ली राधाकृष्णन जी, बड़े लोग थे, अच्छी बातें उन्होंने कही होंगी, नाम्स के बारे में कुछ उम्मीद की होगी उन्होंने अपने भाषण में. मुझे खुशी है कि आने वाली पीढ़ियों ने उन उम्मीदों को पूरा किया जो पहले स्थापना दिवस पर आए हुए लीडर्स ने उम्मीद की होगी इस संस्था से. जो पत्थर अपनी शरीर पर छेनी हथौड़ी खाने से मना कर देते हैं वो सड़कों में लगते हैं. जो पत्थर अपने शरीर पर छेनी हथौड़ी खा लेते हैं वो मंदिरों में लगते हैं. यहाँ जो लोग मंच और अग्रिम पंक्तियों में बैठे हैं, इन्होंने अपने शरीर पर बड़ी छेनी हथौड़ी खाई होंगी. तलवार साहब अपनी तलवार की नोक पर नहीं रखते तो मिस्टर लाल नहीं बन पाते. उस समय थोड़ा बुरा सा लगता है. ट्रेनर्स, कोचेस, प्रोफेसर्स, टीचर्स उन दिनों कहते हैं ये तुम्हारी जिंदगी का बेस्ट टाइम है. मुझे पुलिस में था, एकेडमी में था, तो लोग कह रहे थे ये जीवन का सबसे अच्छा समय है. मैं कहता था तो सबसे अच्छा समय होगा जब पोस्टिंग होगी, वो पहली सैलरी मिलेगी. अब समझ में आता नहीं, वही जिंदगी के सबसे बेहतरीन दिन थे, वो सीखने के दिन थे. मेरी श्रद्धा इसलिए और बढ़ गई है बच्चों को मैंने 16-17 घंटे पढ़ते देखा, तब जाके नीट यूजी में सिलेक्ट हुए, फिर जाकर के डिग्री मिली। शुरू में कोई बता देता कि 16, 12, 13 साल पढ़ना है तो हम शायद डिसीजन और कुछ लेते। फिर इंटर्नशिप हुई, फिर वो अपने को जीरो पे मानने लगे। दोबारा फिर ऐसे लगा कि अब जिंदगी फिर एक उनकी शुरू हो रही है, फिर 16, 17, 18, 19 तक पढ़े होंगे, तब जाके नीट पीजी क्वालिफाई हुआ। गजब की एग्जाम है। 1-2 नंबर कम आ जाए तो पता ही नहीं है देश के कौन से राज्य के सरकारी या गैर सरकारी की कौन सी ब्रांच मिलेगी। सिविल वाले लगभग तय कर लेते हैं कि नहीं इस बार आईएएस ही क्रैक करूंगा, और ज्यादा ज्यादा आईपीएस में हो जाता। ये बच्चे तय ही नहीं करते, उन्हें पता ही नहीं चलता जब तक रिजल्ट नहीं आता है। और एक अजीब बात है कि अपनी मन वांछित ब्रांच ना मिले तो कैसा लगता होगा। तो वो एक एक नंबर लम्हों ने खता की और सदियों ने सजा पाई। 1-2 नंबर घर भी छुड़वा देता है और ब्रांच भी छुड़वा देती है। अच्छा रात दोनों बच्चे तब सिलेक्ट हुए जब मैं एमओएस हेल्थ नहीं था, नहीं तो समझाते समझाते परेशान हो जाता है कि ये नीट एग्जाम 100% बिल्कुल ट्रांसपेरेंसी है। राजनीति में 100% ईमानदार रहने के बाद भ्रष्टाचार के आरोप से नहीं बच पाते हैं। वो कहेंगे इसलिए सिलेक्ट हो गए कि पिताजी मंत्री हैं, और मुझे लगता है कि यहीं बैठे हुए लोगों ने पेपर सेट किया होगा, जरूर किया होगा। ना हम हिम्मत कर पाए कि कुछ हिंट दे दो, और आप ऐसे लोग हैं कि हिंट विंट तो देने की सपने में भी नहीं सोच सकते आप। बेहतरीन लोग हैं। जिंदगी के तलवार साहब से एक 6 की उम्मीद कर रहा हूं मैं। एक छक्का आपको अभी मारना है, 98 है ना? हाँ तो अभी अब आप ये बताइएगा कि 98 के सीक्रेट क्या, अपनी लाइफ की बाकी चीजें छोड़ दो। अब 98 साल तक कैसे स्वस्थ जीवन जिया जा सकता है, इस पे किताब लिख मारो। और हम ईश्वर से प्रार्थना करते हैं कि आने वाली पीढ़ियों को आपका मार्गदर्शन मिलता रहे। संस्था की सबसे अच्छी बात है सीएमई, अपडेट रखते हैं आप, स्किल्ड और एम्पावर्ड बनाए रखते हैं, लाइफ लॉन्ग लर्निंग की भावना। मुझे लगता है बोर्ड से पहले आपके कंधे पर और ज्यादा जिम्मेदारियां थी। और उस जिम्मेदारी को आपने बखूबी निभाया होगा। कई बार मजा मजा आता है कि मेरी फिजिक्स खराब थी, नहीं तो नीचे बैठता ऊपर तो नहीं आ पाता। तो मुझे अपनी हैसियत हमेशा याद रहती है। उसके न्यूमेरिकल्स आते ही नहीं थे। बॉटनी जूलॉजी केमिस्ट्री रटी जा सकती है, तो जिसका गणित खराब होता है उसकी फिजिक्स खराब होती है। इसलिए मैंने बायो स्टूडेंट होने के बाद उन दिनों सीपीएमटी होती थी, उसका फॉर्म नहीं भरा। लेकिन आपसे रिश्ते रहने थे तो भगवान ने एमओएस हेल्थ एंड फैमिली वेलफेयर बनाया। अब एनिमल हस्बेंड्री के बाद मैंने सारी योनियों का मंत्री बन गया। सुनते हैं 33 करोड़ योनि होती हैं। तो जब मैं एनिमल हस्बेंड्री यूपी में था या यहाँ हूँ तो 32,99,999 का मंत्री था। रेप्टाइल्स का भी, पक्षियों का भी, इंसेक्ट्स का भी। और जब हेल्थ एंड फैमिली वेलफेयर दिया तो ह्यूमन का भी हो गया। तो मुझे लगता है भगवान की सारी प्रजातियों का मुझे काम देखने का अवसर मिला। मैं सच में महसूस करता हूं, पूर्व जन्म में हम सब ने, आपने तो, बाकी लोगों ने जल चढ़ाया होगा, आपने दूध में शहद मिला के शंकर जी को टैंकरों चढ़ाए होंगे, जो आप डॉक्टर बने। ठंड में तापते हुए खाने पर जो चर्चा होती है वो चिकित्सकों की होती है, कलेक्टर की कम होती है। जब कोई एक मरीज ठीक होकर जाता है, एक तो अस्पताल में आते हैं सेक्टर भर भर के देखने, ठीक हो जाता है तो सब रिश्तेदार आते हैं, फिर वो कहता है हम तो मर ही गए थे अगर डॉक्टर साहब ने ये ऑपरेशन ना किया होता, इलाज ना किया होता। तो कई बार लगता है कि सावित्री जो छीन के लाई है यमराज से सत्यभान को, आप लोग भी छीन के लाते हैं यमराज से। इसीलिए इतनी श्रद्धा, सम्मान और विश्वास है। अभी तक मैं सोचता था कि, मैं पुलिस में 10 साल रह के आया हूं, कि सबसे ज्यादा मेहनत करने वाले लोग हम थे, क्योंकि कहा जाता है 24 घंटे ड्यूटी है, मना नहीं कर सकते। मुझे लगता है पहरे से उतरने के बाद सिपाही को थोड़ा आराम मिलता है। हम कोई मुलजिम पकड़ के लाते हैं तो उसके बाद कुछ घंटे अपने अनुसार जीते हैं, लेकिन 72 घंटे वाले तो आप लोग हैं। 24 घंटे, 48, वो जेआर शिफ्ट जो होती है ना, भाई गजब की है। मेरे बेटे ने केजीएमसी और बीएचयू छोड़ के इसलिए एसन वो लिया है, इंस्टीट्यूट ऑफ मेंटल हेल्थ आगरा, पेरेंट्स के साथ रहेंगे, और पेरेंट्स के साथ रह ही नहीं रहे। हम हफ्ते में एक आध दिन मिलते हैं, तो इससे तो अच्छा कि मैं हफ्ते में एक आध दिन केजीएमयू चला जाया करता। और ये जानते हुए छोटा शहर है, मैं वहीं से मिनिस्टर हूँ, बट इसका कोई फर्क नहीं होता है संस्थान में आप किसके बेटे हैं। और अच्छी बात है, उसने तो मुझे 5 साल जीएसवीएम में आने ही नहीं दिया, पता ही नहीं चलना चाहिए कि मेरा बेटा है। तो मैं अकेला गार्जियन होगा जो 5 साल तक, तो मैंने कहा अपने बच्चों से मत कहना कि मेरे तुम्हारे ग्रैंडफादर मुझे एक भी बार देखने नहीं आए, तुमने मुझे रोका। और एक बार का अगर आना है तो ओला लेके आना, सिक्योरिटी छोड़ के आना, कुर्ता पजामा उतार के आना। तो मैंने कहा इतने पाप हमने नहीं किए हैं कि अपने को छिपा के हम तुम्हारे कॉलेज में आए। केवल इसलिए कि कॉलेज को पता नहीं चलना चाहिए, ये अच्छी बात है। इसीलिए आपको डॉक्टर साहब गॉड्स इन ह्यूमन फॉर्म कहते हैं, और ऐसा मैंने कोरोना काल के मेरे अपने अनुभव हैं। प्रधानमंत्री जी ने कहा था प्रिकॉशन इज बेटर देन क्योर, 2 गज दूरी है जरूरी, लेकिन इंजेक्शन नहीं बनाया 2 गज का। मैं तो पैरामेडिकल स्टाफ की बहुत तारीफ करता हूँ, वो यहाँ कुछ लगाते हैं ना, इंट्रा क्या कहते हैं उसको, वो तो पास में आके ही लगता होगा। इंजेक्शन भी 2 गज का नहीं था कि दूर से लगा दो। बॉर्डर पर दुश्मनों से लड़ते हुए ही लोग शहीद नहीं होते हैं, बल्कि इतने खतरनाक दुश्मन के साथ लड़ते हुए हमारे चिकित्सक और पैरामेडिकल स्टाफ पैंडेमिक पीरियड में जो शहीद हुए हैं, मैं उनको किसी शहीद से कम नहीं मानता हूँ। क्योंकि डेमोक्रेसी है, लोग स्ट्राइक पे भी जा सकते थे, और वही टाइम था जब आप प्रेशर में ले सकते थे सरकार को। सबने हड़तालें की होंगी, लेकिन जब ऐसी आपत्ति आती है, हमारे चिकित्सकों ने और पैरामेडिकल स्टाफ ने कभी अपने वेतन वेतन की बात करते हुए कभी स्ट्राइक पे नहीं गए। इसके पीछे है कि आपका प्रोफेशन कम है, आपका मिशन ज्यादा है। और शिक्षा और चिकित्सा वो प्रोफेशन प्रोफेशन नहीं है, ये तो मिशन होता है। हमारे यहाँ से लोग इलाज कराने विदेश बहुत जा रहे हैं, आगरा से भी जाते हैं जानने वाले। लौट के मैं पूछता हूँ कि सारे डॉक्टर विदेशी थे? नहीं साहब, उस टीम में इंडियन बहुत थे। तो काय को वहां जा रहे हो? तो विदेश का नाम बहुत होता है ना, जैसे इंपोर्टेड चीज हमें बहुत अच्छी लगती है, परफ्यूम बाहर के अच्छे लगते हैं, कपड़े अच्छे लगते हैं, गाड़ियां अच्छी लगती हैं, और उस टीम में कोई एक नहीं होता है डॉक्टर, मुझे तो लगता है कि मेजोरिटी अब नासा में जाओ तो अपने बच्चे दिखाई पड़ रहे हैं, कहीं भी चले जाएं हमारे भारत के चिकित्सक उस टीम में जरूर होते हैं जो अपने को विकसित राष्ट्र कहते हैं। वो तो बीच में कोई ब्रेकिंग न्यूज नहीं देना चाह रहा, बीच के एक गुलामी के कालखंड की वजह से थोड़ा नुकसान हुआ है। सभ्यता, संस्कृति, धर्म, आध्यात्म, शिक्षा, चिकित्सा, वरना सुसैन और धन्वंतरी के वंशज हैं आप लोग। हमारे यहाँ तो पूरा ग्रंथ है आयुर्वेद पर। मुझे पता नहीं वेदों की उम्र क्या है, 5,000 साल से तो ऊपर ही होगी। पूरा चिकित्सा शास्त्र है अपने ऊपर। पिक्चरों में मैं एक सीन देखा करता था, मुख्यमंत्री या बड़ा उद्योगपति या कोई बहुत बड़ा नेता बीमार है तो डॉक्टर आते हैं, लेकिन उनका बैग जरूर कोई घर का आदमी उठाता है। ये सम्मान तो मिला है। दूसरा, सार्वजनिक जीवन में मैं देखता हूं कि शहर का सबसे बड़ा गुंडा 2 आदमियों के सामने गर्दन झुका के धीरे से निकल जाता है, एक अच्छे चिकित्सक के सामने और एक अच्छे शिक्षक के सामने। जरूरी नहीं है वो बड़े वकील के सामने धीरे से निकल जाए, लेकिन 2 लोगों का लिहाज शहर का सबसे बैड एलिमेंट भी करता है। ऐसा मैं देखा करता हूँ कि धीरे से गुरुजी को प्रणाम करते हुए धीरे से निकल जाता है। और मैं भी कभी प्रोटोकॉल तोड़ता हूं, जहां मैं वो छोड़ के घर पे आता हूं मिनिस्टर को, प्रोटोकॉल को। वो जब मैं शिक्षकों से मिलता हूं या चिकित्सकों से मिलता हूं, उस समय पैर छूने में, मुझे विभाग का मंत्री हूं तो भी मुझे उन लोगों के लिए जिन्होंने अपनी जवानी के बेहतरीन दिन इंसानियत को दिए। आपको अपनी वैल्यू नहीं पता है। आप बिल्कुल ऊसर में, बंजर में अपना नाम लिखिए और उसमें एम्स रिटर्न लिख दीजिए, पीजीआई रिटर्न लिख दीजिएगा, फिर उठाने की फुर्सत नहीं मिलेगी आपको। इसके बावजूद आप ये सरकारी नौकरी कर रहे हैं, तो बड़ी बात है। यही आपको बाकी लोगों से अलग करती है। अगर 7 साल के बच्चे से आप पूछो एम्स को जानते हो, कह देगा हॉस्पिटल है। और 5 साल के बच्चे को ऑडियो या वीडियो नरेंद्र मोदी का दिखा दो तो वो कहता है ये नरेंद्र मोदी है। हो सकता है बाप वोट ना देता हो, लेकिन 5 साल का बच्चा देश के प्रधानमंत्री को शक्ल से, आवाज से पहचानता है। और 7 साल का बच्चा इस देश में एम्स, पीजीआई जैसी संस्था को जानता है। हो सकता है मेदांता को ना सुना हो उसने। श्रीनिवास जी को बधाई कि 98 पर। विश्व तो बहुत बड़ा है भाई, और विश्व में हम 97-98 नंबर पर आए हैं। इसके लिए मैं एम्स के प्रथम डायरेक्टर से लेके आप तक को मैं बधाई देना चाहूंगा। मेदांता 140 पर है। वो ये नहीं देखते ना कि बिल विल कितना लगता है, तो देखते हैं क्वालिटी, इक्विपमेंट्स, मरीज आप देखते हुए। एम्स में, पीजीआई में आने पर खेत नहीं बिकता है, जेवर भी नहीं बिकते हैं। मुझे लगता है ज्यादा ब्याज ब्याज पे भी नहीं लेना पड़ता। ये हमारे इन संस्थाओं की एक विशेषता है। दिमाग में हमेशा एक बात तो रखनी होगी, जिस देश में 80 करोड़ लोग 5 किलो गेहूं चावल निःशुल्क ले रहे हैं, बड़ी संख्या है ये 80 करोड़, 140 में से 80 करोड़, मात्र 12,000 का शौचालय लेने के लिए प्रधान जी के घर पे रोज आते हैं। जितने में एक अच्छा वॉश बेसिन नहीं आता है, उतना में 1,20,000 में प्रधानमंत्री ग्रामीण आवास के लिए 11 करोड़ लोग को मिला है। 1,000 की पेंशन आती है, विधवा, दिव्यांग, वृद्धावस्था पेंशन। लोग वेट करते हैं कब मोदी जी बटन दबाएं, कब उनके हिस्से में 1,000 रुपए आए। सार्वजनिक जीवन के अनुभव बड़े प्यारे होते हैं। मैं जा रहा था कॉन्स्टिट्यूंसी में, तो एक लेडी का रुको रुको जरा, जब 7 बार कोई जीत जाता है तो फिर वो MP नहीं रहता है, वो एक्सियन नहीं रहता है सड़क स्कूल बिजली पानी का, वो गार्जियन हो जाता है। वो रिश्ते हैं आजकल। जबरदस्ती रोक लिया, घर के अंदर गई, एक सरसों के तेल में दीपक जला के, तो घी नहीं होगा, आरती उतारी। यूपी में आरती वारती का सिस्टम कम है, वोट मिल जाए ये बहुत बड़ा एहसान होता है। क्यों इतनी खुश हो? मोदी जी ने मकान दिया है। मैंने वैसे ही सटायर में कहा, अरे कौन सा बड़ा काम है? करीब मैं बाहर छप्पर में सोती थी, जवान महिला हूँ, और रात में कपड़े ऊपर नीचे होने का डर रहता है, शराबियों से बहुत डर लगता है। जब से ये प्रधानमंत्री ग्रामीण आवास दिया है, मैं कुंडी लगा करके झिक के सोती हूँ, माने साउंड स्लीप। तो ये, अब ये लोग अगर बीमार हुए, हम ग्रामीण लोग, मेरा भी छोटा सा गांव है 33 घरों का, 1-2 दिन तो बीमारी को हम लोग देसी लोग नोटिस में नहीं लेते हैं, हम देहाती बूटे। दूसरे दिन चाय में तुलसी उलसी डाल के अपने जुकाम को ठीक करने की कोशिश करते हैं। तीसरे दिन अपने जेब में डले हुए पैसों की हैसियत से उस हैसियत का डॉक्टर चुनते हैं। डॉक्टर कहता है 5 दिन का एंटीबायोटिक कोर्स। मैंने खुद सुना है, मैंने, भाड़ में जाए डॉक्टर साहब आपका कोर्स, क्योंकि आप तो मेडिकल जो तरीका है उतने कोर्स के अनुसार दवाई देंगे। वो कहता है भाड़ में जाए, ये 45 रुपए हैं, इसमें जितनी दवाई आती है वो दे दो। तो नीली पीली गोली बिना रैपर वाली, कागज की पुड़िया में लपेट के वो देता है। हम सबको मरना है, लेकिन आजादी के बाद अगर मैं पहली टॉप 3 काम अगर मानता हूँ विभिन्न अभी तक अपने जीवन के, उसमें नंबर 1 पर प्रधानमंत्री जन आरोग्य योजना के आयुष्मान कार्ड को मैं नंबर 1 पे देता हूँ। 5 लाख प्रति व्यक्ति प्रति साल, और शर्त है वो 2011 की जनगणना में नाम हो, अथवा उज्ज्वला का सिलेंडर हो, अथवा अंत्योदय कार्ड धारक हो, अथवा ई लेबर कार्ड हो, अथवा यूपी में राशन कार्ड में 6 नाम हो। 1 मिनट में बन जाता है वो। जब मैं किसी को राशन कार्ड की बात करता हूं तो कहता है भाड़ में जाए राशन कार्ड, मंत्री जी हमारा आयुष्मान कार्ड बनाओ। लेकिन कंप्यूटर हमारी बात नहीं मानता जब तक ये 5 में से कोई एक योग्यता ना। दूसरा, आप डॉक्टर हैं, ज्यादातर बीमारियां दूषित पानी से होती हैं। घर में नल और नल में जल, और आगरा वाहिद वो शहर है यमुना के किनारे लेकिन गंगा जल। तीसरा, नॉन गस्टेड नौकरियों के इंटरव्यू समाप्त होने को मैं बहुत बड़ी चीज मानता हूँ, क्योंकि इंटरव्यू लेने के लिए नहीं होते थे। नॉन गस्टेड के इस बात पे इंटरव्यू ले रहे हो, रिटर्न में ले लो जो भी पूछना है। कुछ जिंदगी भर पानी पिलाते हैं, फाइलें ही लाते हैं, उनका इंटरव्यू क्यों हो रहा है? पूछ लो रिटर्न में, नदी कौन सी लंबी है, पहाड़ कौन सा ऊंचा है, मुद्रा कौन सी है, राजधानी कौन सी है। इंटरव्यू लेने के लिए नहीं होते थे, इंटरव्यू निकालने के लिए होते थे। लेना है तो आगरा की स्पेलिंग बता दे, नहीं लेना है तो तू चेकोस्लोवाकिया की बता। और मेरे जैसे लोग चेकोस्लोवाकिया की भी बता के सिलेक्ट नहीं हुए, क्योंकि चेयरमैन साहब को एक सूची आ जाती थी मुख्यमंत्री कार्यालय से। तो बच्चन का बहुत आप इंटरव्यू समाप्त होने को बहुत बताते हो। मैंने कहा अपने पिताजी से पूछना। हम लोग हाई स्कूल इंटर की मार्कशीट को मोम या पॉलीथिन में मढ़वा के रखते थे, रोजगार कार्यालय के चक्कर काटते थे, निकले हुए फॉर्मों को भरते थे, लिखित परीक्षा पास करते थे। पिताजी पे नोट नहीं थे और बिरादरी पे बड़ा नेता नहीं था तो चेयरमैन को प्रभावित कर सके, इसलिए बेरोजगार हो जाते थे। अब आ रहा है तो ले नहीं पाओगे। आप अपनी मर्जी से किसी को नौकरी दे सकते हैं, भले आप PGI और एम्स के डायरेक्टर, नहीं दे सकते आप। ये बड़ा काम है। लेकिन आयुष्मान तो, शिक्षा और चिकित्सा समान होनी चाहिए। करेगा कौन जब मैं खुद सरकार का एक अंग हूँ? शिक्षा के भी इतने स्टैंडर्ड नहीं होने चाहिए थे। पहला स्टैंडर्ड देहरादून का दून स्कूल, अजमेर का मेयो कॉलेज, ग्वालियर का सिंधिया, नैनीताल का सेठ बोर्ड, फिर पीटर्स फेटिक चार्ल्स जॉर्ज चिटिगोन का, फिर नीली पीली टाई लगा करके अधकचरी अंग्रेजी। लास्ट वाले हमारे वाले जो हम जिला परिषद के स्कूल से पढ़ के आए, जहाँ बैठने के लिए बोरी भी अपनी ही लेके जाते थे। कक्षा 6 में हमको अंग्रेजी पढ़ाई जब हम 11 साल के हो गए। GK हमें कभी पढ़ाई नहीं। और ये धौलपुर हाउस भरतपुर हाउस है, धौलपुर हाउस यूपीएससी कहाँ है? धौलपुर हाउस से जब पहला बैच निकला था तो अंग्रेजी जरूर थी, पेपर और जीके जरूरी थे, और हम देहातियों को दोनों विषय पढ़ाई नहीं गए कभी। तो समान शिक्षा हो जाती। प्रथम राष्ट्रपति राजेंद्र प्रसाद जी का नाती और राष्ट्रपति भवन के चपरासी का बच्चा, दिल्ली के कमिश्नर का और सिपाही का और मंत्री का और संतरी का और नगर सेठ का और भिखारी का बच्चा एक हॉल के नीचे एक ही सिलेबस पढ़ रहे होते, तो गांव गांव में बच्चे डॉक्टर, इंजीनियर और आईएएस हो गए होते। अब पांचवी प्रकार की शिक्षा हम लोग ले रहे हैं, तो सुबह आधे घंटे में ऊपर वाले बच्चे रगड़ देते हैं। ये इस विषय का नहीं है, लेकिन दुनिया में कोई काम हैसियत से बढ़ के करेंगे तो बर्बाद हो जाएंगे। एक ही काम है जिसमें हैसियत मिटाएंगे तो आबाद हो जाएंगे, वो अपने बच्चों की अच्छी पढ़ाई पर अगर हम अपने आप को मिटा देंगे तो एक दिन सब कुछ वापस आ जाएगा। आपके पेरेंट्स बड़े अच्छे थे, जिनकी प्रायोरिटी एजुकेशन 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 थी। उसकी प्रायोरिटी होती है खेत खरीदना, खेत खरीदना, खेत खरीदना। आपके पेरेंट्स की थी बच्चों को पढ़ाना, बच्चों को पढ़ाना, बच्चों को पढ़ाना। माता शत्रु पिता बैरी येन बालो ना पठाती, न सोबते हंस मध्य सभा मध्य बको यथा। वो सब माएं अपने बच्चों की बैरी और पिता दुश्मन है जो अपने बच्चों को पढ़ाते नहीं है। ऐसे बच्चों की वही स्थिति होती है जो हंस की सभा में बगुले की होती है। वापस आपके तीन शब्द एटम बम से भी पावरफुल हैं। शिक्षित बनो, संगठित रहो, संघर्ष करो। प्रायोरिटी ये क्यों रखी? सीधे संघर्ष में क्यों नहीं झोंका? जब तक समाज शिक्षित नहीं होगा, संगठित नहीं होगा, संगठित नहीं होगा, तो संघर्ष के रास्ते पे नहीं चल सकता। तो मैं जब 5 बार एमपी था तो 387 मेडिकल कॉलेज थे। जब मैं 15 प्रधानमंत्रियों का लेखा जोखा दिखा रहा हूं तो 387 थे। अब मेरे इस 2 कार्यकाल में, माने मोदी जी के कार्यकाल में, 14 से 24 में 706 हो गए। तो भावनाओं से पढ़ाई होगी या उसके लिए कॉलेज की जरूरत होगी? तो 4 10 साल 8 महीने में मेडिकल कॉलेज दुगने हो गए। क्या पॉपुलेशन 10 साल में दुगनी हो गई? इसलिए हम लोग जब पहली बार कहते हैं तो थोड़ा, मैं बहुत राजनीति को मंच पे नहीं लाना चाह रहा, लेकिन आंकड़े हैं जो चीख चीख के कह रहे हैं कि मुझे विरासत में मोदी जी को 387 मिले थे और अब 706। जनसंख्या दुगनी नहीं हुई। यूजी सीटें 51,000 थी, जस्ट दुगने से भी ज्यादा 1,07,000 है। तो कहीं ना कहीं मरीजों को लाभ होगा, जनता को लाभ होगा। पोस्ट ग्रेजुएट सीट 31,000 थी, अब 70,000 है। तो मैंने जब बेटा सिलेक्ट हुआ कहा भैया मोदी जी को धन्यवाद का पत्र जरूर लिखना, 31,000 होती तो शायद तुम्हारा सिलेक्शन नहीं होता। 70,000 हो गई है तो उसका लाभ आपको जरूर मिला होगा। 22 एम्स हो गए, शायद 14 थे जब विरासत में 14 मिले थे, अब 22 हैं। तो आयुष्मान भारत डिजिटल मिशन भी है। 50 करोड़ हो गए हैं अब आयुष्मान कार्ड। 9,19,00,000 लोग ट्रीटमेंट ले चुके हैं और 1,29,00,000 रुपए पैसा खर्च हो चुका है। ये फाइल कभी कभी मेरे पे भी आती थी। 31,005 हॉस्पिटल हैं और 40,60 करोड़ आयुष्मान कार्ड बन चुके हैं। आयुष्मान कार्ड की बहुत अच्छी बात है कि ये पूरे परिवार का बनता है। इस बार आपके फादर का बना तो आपका बनेगा, भले अगले साल आप नीट क्वालिफाई कर लें, आयुष्मान कार्ड, भले सिविल क्वालिफाई कर लें, आयुष्मान कार्ड रहेगा। तो जेब में डाल के रखना चाहिए। वन नेशन वन आयुष्मान कार्ड, वन नेशन वन राशन कार्ड, वन नेशन वन टैक्सेशन, वन नेशन वन ग्रिड। अच्छा हो जाए वन नेशन वन इलेक्शन भी हो जाए, जिससे रोज की आचार संहिता से हमें भी मुक्ति मिले। जब देखो तब सरकारी गाड़ी छिन जाती है, जब देखो तो तब आचार संहिता लग जाती है, उद्घाटन समापन बंद हो जाते हैं, घोषणाएं बंद हो जाती हैं। तो ये वन नेशन वन इलेक्शन हो जाए तो उससे बहुत बहुत धन्यवाद। आपने मुझे याद किया, बहुत बड़ा मंत्रिपरिषद है, उसके बाद आपने मुझे याद किया और इतनी बड़ी संस्था में मुझे आने का आपने अवसर दिया, और उससे ज़्यादा हमारे जो इतने सीनियर गार्जियन, नवरत्न, पद्म श्री, पद्म भूषण, ये समाज सेवा थी आपकी, सरकारी सेवा नहीं थी। समाज सेवा की ये पगडंडियां सच में एक दिन राष्ट्रीय राजनीति के राजमार्ग पर ले आती। टीपी ठाकुर साहब आई ना, हर्षवर्धन जी आए, और जिनको राष्ट्रीय राजनीति नहीं पसंद है तो समाज सेवा की ये पगडंडियां एक दिन राष्ट्रपति भवन के अशोका मार्ग में, अशोका हॉल में पद्म पुरस्कारों के लिए ले आती है। और मोदी सरकार में एक बात तो है कि खुशबू अगर पीएमओ और राष्ट्रपति भवन तक आ गई तो फिर आपको सरप्राइज होती है कि आपको इस तारीख को पद्म पुरस्कार लेने के लिए आना है। अब जुगाड़ बंद हो गई है। अब एमपी एमएलए 10 लेटर लिख दें उससे कोई फर्क नहीं पड़ता है। अब आपकी खुशबू प्रधानमंत्री के कानों तक, राष्ट्रपति भवन तक आ जाती है तो एक दिन एक फोन आएगा, और ऐसे ऐसे लोग अब पद्म पुरस्कार पा रहे हैं, जब उनके बारे में बताया जाता है तो ताज्जुब होता है। 1 लाख पेड़ लगा दिए, ये कर दिया, वो कर दिया, और वो एक जोड़ी कपड़े भी नहीं सिलवाते हैं कि राष्ट्रपति भवन जा रहे हैं तो एक अलग से सूट वूट कपड़े उपड़े सिलवाए। बड़े सहज लोग होते हैं। मैं एक बात चाहता हूं कि पद्म पुरस्कारों की संख्या कम है, विभिन्न क्षेत्रों में काम करने वालों की संख्या बहुत ज्यादा है। इसलिए गाहे बगाहे संस्थान को, एनजीओ को, सोसाइटीज को, ट्रस्ट को सम्मानित करते रहना चाहिए। ये अवार्ड एक शॉल थी और एक बुके था। घर में कोई जगह नहीं है अब इनके यहाँ जहाँ ये उस इसको रख सके, मोमेंटो को। है कोई जगह अब? बची नहीं होगी, बोरों में भरे होंगे आपके घर। घर तो 2-3 कमरों का होता है, ड्राइंग रूम कब तक रखें? लेकिन उसका महत्व बहुत है। 9 साल की उम्र में जब मैं कक्षा 4 में पढ़ता था, मेरे टीचर ने मेरा नाम अंताक्षरी प्रतियोगिता में लिख दिया और मुझे मानस की चौपाइयां रटा दी। तो मैं अपना ब्लॉक जीता, फिर तहसील जीता, फिर अपना जिला जीता। उस जिला जीतने पर अवार्ड के तौर पर रेक्सोना साबुन की सबसे छोटी वाली साबुन की टिक्की मिली। अगली लाइन अच्छी है, जिसकी खुशबू से मैं आज तक महक रहा हूं, क्योंकि उस अवार्ड की साबुन की टिक्की ने 9 साल की उम्र में पैरों की कपकपाहट को बंद कर दिया, माइक का डर दूर कर दिया और स्टेज का फोबिया दूर कर दिया। अब हम कहीं से भी भाषण दें, सामने एम्स के 22 डायरेक्टर बैठे हों, या मैं लॉ एंड जस्टिस में था, सुप्रीम कोर्ट हाई कोर्ट के जजेस साहिबान हों, मैटर खराब हो सकता है। क्योंकि मैं पढ़ता पढ़ता नहीं, मैंने लिखा हुआ नहीं पढ़ता, लेकिन पैर नहीं कपकपाते, जवान नहीं लड़खड़ाती, स्टेज का डर नहीं लगता। थोड़ा भय रहता है जब आप लोग ऑडियंस में बैठे होते हैं, लेकिन मानो पैर नहीं कपकपाते। उस रेक्सोना साबुन की टिक्की का कमाल है। तो ये आप लोगों को अवार्ड मिले, और ये एक दिन में नहीं मिलते हैं। ये फूल मुझे यूं ही विरासत में नहीं मिले, मुझे नहीं, आपको। तुमने मेरा कांटों भरा बिस्तर नहीं देखा। और ये सब, मेरे बेटे ने कहा कि जो जो ये अवार्ड पाते हैं ना, वो छोटे उसके मरीज हैं, छोटे से हल्के से मरीज। वो मेंटल हेल्थ देख रहा है इसलिए। ये जुनूनी लोग हैं, थोड़े से हल्के से साइको होते हैं, दूसरों से ज्यादा काम करने वाले होते हैं। और ये घोड़े, जैसे घोड़े के ऐसे लगा देते हैं ना, ये शुरू से ही वो लगा लेते हैं, ये दाएं बाएं देखते ही नहीं है। ये अपना लास्ट मंजिल। तो मैंने कहा नहीं, ये वो वाले घोड़े भी नहीं है जो दाएं बाएं नहीं देखते हैं, केवल मंजिल देखते हैं। मेरी जिंदगी एक मसलसल सफर है, मंजिल पे पहुंचा तो मंजिल बढ़ा दी। ये आप लोग वो लोग हैं। और जब से मैं चला हूं मेरी मंजिल पर नजर है, इन आंखों ने कभी मील का पत्थर नहीं देखा। तो बहुत बहुत बधाई, आपको शुभकामनाएं। मेरा सौभाग्य है कि नेम जैसी संस्था में, नाम जैसी संस्था में मुझे आने का मौका मिला। नाम्स अपने नाम को चरितार्थ कर रहा है, अपने नाम में रोज कुछ नगीने लगा रहा है। थैंक यू वेरी मच, बहुत बहुत धन्यवाद। आपने मुझे याद किया और मुझे अपनी फिजिक्स याद आई कि जो ना आने से मैं इस बिरादरी में का सदस्य नहीं बन पाया। लेकिन जब बच्चे जो बन जाते हैं तो अपने सपने पूरे हो जाते हैं। मुझे अच्छा लगा कि 72 घंटे वाले लोग हैं ये लोग, टिफिन भूल जाते हैं या नहाते नहीं हैं कई कई दिन, तब जाकर के इस स्टेज पर आते हैं। इसके बाद जब किसी नर्सिंग होम में या अस्पताल में कोई मरीज मर जाता है तो पूर्व प्रधान या प्राइमरी का टीचर या हमारे जैसा नेता जो एनासिन की स्पेलिंग लिखना नहीं जानता है, वो आपके प्रिस्क्रिप्शन की आलोचना करता है। ये नहीं होना चाहिए, ये बिल्कुल भी नहीं होना चाहिए। तो कोई भी नहीं चाहता है कि उसके अस्पताल में कोई मरे, और उसके पीछे क्या हिडन एजेंडा होता है जनता का मुझे नहीं पता। लेकिन मेरा निजी तौर से संरक्षण कभी नहीं रहा। मैं झोला छाप डॉक्टरों के खिलाफ हो सकता हूँ, लेकिन किसी ने एमबीबीएस किया उसके बाद मेरी श्रद्धा उस व्यक्ति के लिए बहुत ज्यादा बढ़ जाती है। बहुत बहुत धन्यवाद। थैंक यू वेरी मच।
माननीय मंत्री महोदय, सहृदय धन्यवाद, आभार। कहते हैं व्यक्ति की पहचान वस्त्रों से नहीं, विचारों से और व्यक्तित्व से होती है। आप जितने बहुआयामी प्रतिभा के धनी हैं, स्वभाव में, व्यवहार में उतनी ही विनम्रता, सहजता है। May I now please request Dr. Neerja Batla, Vice President, NAMS, to deliver the words of gratitude. Dr. Neerja.
I think it has been a most fascinating session that we have had with the luminaries. And on behalf of NAMS and the Council, it's my proud privilege to deliver the vote of thanks. And really no words to thank Honorable Minister Shri Bagelji for finding the time from his busy schedule to come and enlighten us. I think it has been both enlightening, both entertaining, and very thought-provoking to hear his mix of advice, personal experience, insights. Very, very nice. And sir, I'm sure it will go a long way to the ripple effect that you have created today. I think it will go a long way with our people. And many, many thanks also to Dr. M. Srinivas and Dr. Vivek Lal, who are both very, very busy directors of prestigious institutions, and to find the time again to come to speak to our people. And I would also thank all the past presidents who are here, who are gracing the occasion. Dr. Ganguly, Dr. Talwar, Dr. Sareen came for a short while, Dr. Chudamani, and President of Presidents, Dr. G.P. Talwar. Sir has been, when I joined AIMS in 1976, Sir was the head of Department of Biochemistry. So it's a really, really long association. And from all of them, we have had very, very close personal relationships. They have been so involved, and we really appreciate their coming and giving their time to us. And as well as I would like to thank also all the council members, the fellows, the associate fellows, the new awardees, the NAMS who are here. And last but not the least, many thanks to the entire office staff with their team led by Dr. Umesh Kapil, Madhuri, and all the office staff who have worked tirelessly for this event. Thank you, Dr. Bera, for the opportunity. Thank you, Dr. Nair, for all your insightful inputs, and the function has gone as good and better each year. I think we have better and better insights as we go along. So thank you very much, and please join us for a cup of tea.
Thank you, Dr. Neerja Batla, and to all the members of NAMS who are present here, with whose contribution NAMS has come to this great milestone where it is today. And thanks to the office staff, Dr. Umesh Kapil, and all the members of NAMS. Please rise for the national anthem. अनधिनायक जय भारत भाग्य विधाता पंजाब सिंध गुजरात जलधि तरंग तब शुभ नाम जागे गाये तब जय गाथा जब Thank you, everyone. Please join for the group photograph on the stage. NAMS staff, please come for the group photograph first.
हाँ जी ये वाला चलता बिहार का अपोलो अहमदाबाद में गुजरात और महाराष्ट्र गुजरात वहाँ अहमदाबाद
Sir, can I have one photograph, please? Thank you. Thank you. Thank you.